எக்ஸ்டர்னலுக்காக மட்டும் பாருங்கள்.
டைமர் எங்கே வச்சுக்கிறேன்? எங்கே வச்சுருக்கேன்?
அப்படியே ஓப்பன் பண்ணி அப்படியே தான் ரெடியாக இருக்கும். அது ஓடின்னு தான் இருக்குது எக்ஸ்ட்ரா ரூம். ஏதோ ஒரு பிபிடி ஓப்பன் பண்ணி பார்க்கலாம்.
ஓ கண்ட்ரோல் விட மாட்டேங்க.
இதில் வா இந்த பக்கம் வாங்கலாம். இல்லைப்பா வந்துச்சு பாரு, இது வந்துச்சு பாரு, மவுஸ் வந்துச்சு.
அப்படியே விடு, ஏதோ நீ மாட்டாது.
Okay, no? Ready with this song? Okay. Good morning, friends. We'll start with this opening prayer song. Those who know it, please join it and sing with your full heart and soul. And let's have a joyful day today.
Thank you.
Shine, Jesus, shine. Fill this land with the Father's glory. Praise, Spirit, rain. Set our hearts on fire. Oh, river flow, flood the nation with grace and mercy. Send forth your word, Lord, and let there be light. As we gaze on your kingly brightness, so our faces display your likeness, ever changing from glory to glory. Mirrored here, may our lives tell your story. Shine on me, shine on me. Shine, Jesus, shine. Fill this land with the Father's glory. Blaze, Spirit, blaze. Set our hearts on fire. Oh, river flow, flood the nations with grace and mercy. Send forth your word, Lord, and let there be light.
I praise God for this time. Yeah. Let's read a Bible verse that is taken from Psalm number 89 and Proverbs chapter 16, verse 3. I'll sing of the mercies of the Lord forever. With my mouth will I make known your faithfulness to all generations. For I have said, mercy shall be built up forever. Your faithfulness you shall establish in the very heavens. Commit your works to the Lord, and your thoughts will be established. As we begin our workshop today, let us look to the Lord in prayer. God the Almighty, the source of all our blessings, we thank you and praise you, Lord, for your sustaining grace and everlasting presence hovering on our institutions. Lord, especially we thank you, Lord, for this regional anesthesia workshop that you all enable us to come together over here to have the meaningful day, O Lord. God, as we begin this workshop today, we ask your guidance and wisdom to be upon us as we explore the new ideas and perspective, O Lord. God, you may enable all of us to be receptive in our minds to the knowledge and to embrace all the understanding, O Lord. Lord, we pray for all the presenters, facilitators, and attendees, God. You may bless all of them through all your wisdom, knowledge, so that, Lord, whatever the conversation, collaboration is going to take place, it will be really strengthening the department, the people who have come together here as we carry your healing ministry, the society where we go and serve you, Lord. We submit all of us into your care. You may guide us and lead us through your presence, spirit, and protection, O Lord. Thank you, Lord, for listening to all our prayers. In Jesus' name we pray. Amen.
Good morning. Greetings and welcome to each one of you all. At the outset, I'd like to thank our God Almighty, our Lord Jesus Christ, for giving us life and the gift of a new day for us to gather here and experience all that is planned for this day. I would like to thank God for our great institution, the Christian Medical College and Hospital Vellore. This year we celebrate our 125th year of its existence. We thank God for God's faithfulness and enabling this institution to stand tall and stand the test of time and grow from strength to strength. I'd like to thank our Department of Anesthesia headed by Dr. Hector Rai for giving us this opportunity to conduct this CME workshop and the freedom for Unit 2 Regional Anesthesia Unit to do it the way we wanted to do it. There is no regional anesthesia without anatomy, so I want to acknowledge and welcome and thank the Department of Anatomy headed by Dr. Tripti and their supporting staff. Thank you so much for all the arrangements that has been made. They have also worked so tirelessly. So I welcome all the external faculty who have come from far off places. Thank you one and all for accepting our invitation. I know it's not a direct venue to come to, direct city to come to, but you have taken the pain and the effort to come here. Really appreciate that. I also welcome the external delegates who have also come from far off places and made this effort to come here. I won't be standing here without the support of my internal faculty. So I really appreciate you all and thank you all for coming. We have several things planned out for you and we encourage you to interact with one another and do ask questions and feel at home so that we'll have a good day in all the activities that has been planned this day. So welcome each and everyone. Please feel free to come again even after the workshop is over. So let us have an enjoyable day, all the food and the hospitality, and do attend every segment of it and have a great day. Thank you. Now without much ado, we will go on to the didactic lectures. I'll call upon Dr. Arish to give his lecture. Thank you.
Am I audible? Am I audible? Can I get a pointer here? Is it possible? Pointer. No, in that arrow. Laser pointer. Yeah, I know that. You have a pointer here in this. Is it possible to have that? I think it's working on my screen. Okay, fine. So very good morning to one and all who are here. It is an honor to be standing in CMC, one of the prestigious institute of our country, and very happy to share the stage with esteemed faculty members who are here today. So today I'm going to talk about regional anesthesia, an overview of all the blocks, and certain current trends involved in that, and very little about your future directives. So greetings from Pondicherry Institute of Medical Science. This is the place where do I work, and there is no conflicts of interest, and I really wanted to thank the Department of Anatomy of PIMS and Dr. Shivashankar sir from MGMC for some works that I'm going to present as slides here. So the synopsis will be like this. I'm very sorry, actually this is the old one. The older form has been opened. It is in the faculty, is possible? Faculty. Final. Please open the final if possible. Yeah. This is there. Yeah. Yeah. This is the slide. So I'm going to talk about certain important knobologies and ergonomics in a very short, because madam wants to know about certain important knobologies which we really need to get a good image acquisition, and how do my peripheral nerve block works. So what is the critical volume and concentration which I need to get a good conduction blockade. And then we are going to see about the core A blocks only because of time constraints, and how to implement few clinical anatomical pearls with our clinical practice. This is how it will be the flow today. So the coming to the history is a very short history, that where we started put our needle inside the nerves and we try to elicit paresthesia, and we try to give more amount of volume and achieve a conduction blockade. Later we moved one step ahead and we started using nerve stimulators, and thereby we elicit the motor response, and we came down of the volume and we know where we are correctly placed, but still we are not achieved the target, which was being a real-time image. Now we can able to see where is your target is placed by using this ultrasound. So by this we have got the help from our superhero Batman. How? So bats tries to use their ultrasonic waves almost 20,000 hertz and gets back the signal and it hits the target. So in ultrasound by Pierre Curie, we have just inverted this piezoelectric crystals, where these elements, when subjected to some current, it tries to expand and sends the signals, and it compresses and gets back the signals, and it's just like a high speed switch, switches on and off, and thereby we are able to get an image in a gray-white scale, right? So a little bit of ergonomics, because I'm running fast because I wanted to say something in the back. So ergonomics, always the operator, the needle and the transducer and the monitor should be along your visual axis. You may change across the visual axis of both the transducer and needle, but everything should be in plane. And the holding of the probe should not be like this. It should not be holding the tail or with the hand, or too much of extension and flexions of your neck, and there should not be too low or too high. So that's why how to hold the probe is much more important to get your image in a better way. So we have to hold with the thumb and the index finger and try to rest your hypothenar over the patient table or over the patient. So for instance, to give an example, how to perform a supraclavicular blocks, what is the ergonomics? This you can see it's all in visual axis, and you can see this is performed in the left sided ear, where they hold the probe and he's placing his whole forearm over the patient's chest. How is this so? You have to make 45-degree head up position. I usually prefer to do this in this way, so that it will be easy to navigate your needle underneath. Next, the most common performed nerve in lower limb will be a popliteal sciatic. Most of the times what we do is we go and face the popliteal area and try to place the probe, which will make you to slip over. So what I do advise is go and face the patella of that patient and place all your forearms over the thigh of the patient, so that your probe handling will be better. It will not slip away and it will be easy to needle it in along your visual axis. Okay? So coming to certain knowledges which is going to be highlighted, once and foremost we should know our machines, what we are using. So here we should know where is the power supply, and you have to choose which probe do I going to use, whether I'm going to use my high frequency or low frequency probe. Next is, we have to know what is a preset, what is my subject of interest, whether I'm going to see a nerve or vascular structure, that is more important. And then you have to identify the probe orientation marker. It is very easy, because unless you identify this, we'll not know which structure we are dealing with, whether we are dealing the medial structures, whether the structures which are visible is towards me, whether the needle goes from medial to lateral or lateral to medial. Is just place a jelly and then try to put your finger over the top. It will be very easy to know. Then only you will have an orientation, whatever the slides which all people are going to see in your stations. Otherwise you will not know which is medial or which is lateral. The next is gain. Newer machines do have an overall gain button. So this gain dictates what is your image is going to be. It either will be in hyperechoic or it may be hypoechoic. And older areas, they may have this time gain compensations where you can specifically decrease your gain in certain areas. But the disadvantage is you may miss your target if it already decreased the gain here. So that is more important. So time gain compensation, you have to adjust it. And the next is depth. This is more important to improve your temporal resolution. This is an example of your infraclavicular block where you are able to see all the structures of the cords here. But if you are going to increase the too much depth, your area of target will not be seen, or if you decrease the depth, you lose your target of interest. So adequate depth is almost necessary. And the next most important is you have to make your area of interest in a to be putting it in the focal zone. Otherwise, you will miss your lateral resolution. Lateral resolution nothing but you are going to see two structures in a separate lateral area. So there are some parts in your ultrasound beam, that is near zone, focal zone and far zone. Try to always place your image of interest in the focal zone. Then the other panel buttons, you know how to do it, a little bit of calipers and calculations and freezers. Most important button, if you ask me, I'll just say your Doppler button. Try to always put a color Doppler in whatever area of you're going to block. That is more important. You may have multiple vascular structures, and if I'm going to scan you all, you may have multiple anatomical variations of your own arteries. So it is better not to inject intravascular. So you need to put a color Doppler, and most important point here it is, never mind about blue or red, you should not inject intravascular, because whatever the Doppler mode you're going to use, your area of target should be parallel to the probe. Then only will get this red or blue, whatever it is. If it's flowing towards it, will be red or away. But if you're going to insinuate more than 30 to 45 degree, or if you're going to place it just perpendicular to that vessel, you will not even pick up a color inside that. That is more important. Thinking that something is a muscle or something else, you will 100% inject in that, inside vascular. So that is more important that I wanted to highlight here. This is the most important. After your better acquisition of your image on endpoint scanning, please put a color Doppler. If you take this point alone from my slides, I'll be very happy. The next is the probe manipulation. You have to pressure, align, rotate. All those things we'll be dealing in the stations. We'll be saying which are the maneuvers is useful for the areas of blockade. Okay, and this comes by hand-eye coordination. If you ask me, it comes only by your learning curve. So you have to practice as much as possible. Fine. So I think we are all ready to hit the targets. Okay, shall we go on some of the core A blocks? So how my peripheral nerve block works and what is my critical volume and concentration. I think everyone can have a look at this. This is the most commonest problems that we face with our surgeons every day. These are the problems. So we'll try to tackle it, how far we are able to. I think at the end of this, we'll be able to manage it. So how we are going to do that? This is the impulse propagation where it propagates to an axon, right? And how we are going to do it? Here you can see the nodes of Ranvier where the density of sodium channels are much more. And by studies we know that the internodal distance is almost 0.2 to 2 mm. And by studies we know that the impulse propagation is a saltatory conduction, and we need at least 3 nodes of Ranvier to be blocked, and more than 70% of sodium channels has to be blocked to have a good conduction blockade, right? So how we are going to achieve this? By volume and concentration. So coming to volume, for an example, if I take a 6 centimeter long axon, and if I'm going to put 1 ml of local anesthetic in that, as the nerve comes out from the center to periphery, it takes more layers along with it. So one more factor comes into play here, it is the surface area. So as the surface area increases when it comes to periphery, that 1 ml you can see in that syringe, you will be able to only block some 0.3 to 0.5 mm of your axon. So you will not be able to achieve your 3 nodes of Ranvier, you will not be able to block it. So this means that the neural to the connective tissue ratio increases when the nerve comes out from the center to periphery, right? And this is an example for that, where you can see an interscalene where it is for your C5 and C6. You will have the same structure, you will be seeing an hypoechoic inside and hyperechoic rim. When the same nerves, when they come to a supraclavicular brachial plexus, you see we called as a bunch of grapes. Just look at the image of that itself, it shows how much connective tissue, the ratio to connective to the neural ratios are more. So here you will use only little volume, and here you need at least 20 to 25 ml to block a good conduction block. So as the surface area increases, the volume has to increase. So I was talking about nodes of Ranvier, right? So which nodes of Ranvier should I block? Because there are many fibers from A delta to C fibers, and the sodium channels are more densely packed in A alpha. Okay, if you have an electron microscopic view, these are much more myelinated, right? I think we know that. So we need some more concentration to block that A alpha fiber when compared to the C fibers. And if you're able to achieve that, and if you're able to do your local anesthetic concentration towards the core of that A alpha, the remaining things will be already blocked. Once you were able to block A alpha, obviously all the fibers would have been blocked. So for this we need some concentration. So concentration is nothing but the amount of drug in the unit volume. So for this I'm going to extrapolate or get help from an epidural where we day in and day out we perform. And most of the times we use bupivacaine on a concentration of 0.15 to 0.35. Here, when you use here, you're able to block A, delta and C fibers, and most of the times labor epidural where you place catheters, this is what you perform, right? Every day in and day out. But when I touch 0.25, maybe some amount of A delta fibers, depending upon the sensitivity of the patients, you may block some sensitivity or even sometimes motor. But when you touch 0.375 and plus, you will be blocking all the fibers. That is what is there in our peripheral nerves also. It is combined of all the fibers from A delta, A alpha and to C fibers. And you will get a surgical anesthesia. That is what we want, right? So for volume, I just wanted to get your interest, or I just wanted to try to impress you with this. So to have a lower limb surgery, we need at least T10, right? I think everyone will agree here. And almost one lower limb of, if you concern from T10, if you calculate, there will be 3 lower thoracics, 5 lumbars, 5 sacrals, almost 13 in one lower limb. And if it is almost 26 nerve roots bilaterally, you need just 3 ml of 0.5% of bupivacaine to soak all these nerve roots. And if you dilute it in 50 ml of lumbar space, it is almost 0.03%. But imagine in your brachial plexus, it is just 5 roots, and you know how much amount of volume that you need is almost 30 ml. So this is how, because of this image you can see here in the central neuraxial, after placing your drug in the subarachnoid space, it is only one layer of a pia mater and a little bit of endoneurium here, you can achieve your target of nodes of Ranvier and concentration. Just imagine on that picture on your, towards your right, that is a sciatic nerve component. Like, it is full packed of many layers, that is epineurium, perineurium and endoneurium. Your local anesthetic has to travel all this distance to give your conduction blockade. So that's why you need a higher volume there. So another layer is known as the paraneural sheath, which is one of the components. They say it has been engulfing both your common peroneal and your tibial. So here you have to place subparaneural injection to give your good onset of blockade, right? So now I hope you got the answer. Now you know what is your critical volume to block your 3 nodes of Ranvier. And as the surface area increases, you have to increase the volume. And the next is my concentration, it should be at least more than 0.375 to get a good conduction blockade, right? Is that okay now, till now? Fine? So where do I place? Always try to place your needle interfascicular for a good onset. Never place it inside, that is known as intrafascicular. You may land up in much of neural or nerve injuries. And if you're going to place it much more extra neural, there will be much more taking of your onset time and your block will be in failure, okay? So next, for the next 15 minutes or 10 minutes more, I'll be talking about few anatomical pearls, what you have to do it for various core A blocks. So for that you have to know whatever the block you perform, you should be knowing your dermatome, myotome and osteotome. Fine? Because most of the times we spare certain dermatomes and myotomes and we convert to GA. You should know which dermatome is involved and you can go for your rescue blocks rather than to convert to GA. So these are the core blocks. I'll be covering only maybe not populated. I'll try to a little bit rushing through it. So most your clavicle and your shoulder surgeries, you do perform your interscalene brachial plexus, right? So if I'm going to scan you people, most of the times this C6 will split into two. And that's why they say this traffic light signal that whatever you see, it's no more the traffic light signals. Because if you try to inject there in between two C6, you will be ending up in intraneural, and if your injection is pressure and volume is more, you will get a nice epidural. Fine? So please do not do that. Try to scan how the C6 divides, whether into 2 or 3. It will split into 2 or 3. Fine? So next is, you have to know the osteotome of your anterior joint, where most of the times, almost by cadaveric studies, 75% it blocks by the suprascapular nerve and axillary nerve, and little bit of anterior superior quadrant and inferior quadrant, you will get your nerve to subscapularis. And the muscles which supplies there, all the rotator cuff muscles and the incision muscles over there, it is most of the time it's your C5 and C6. Right? The only problem is with your dermatome, which is by your supraclavicular nerves, which is not a part of your brachial plexus or your interscalene. So you need to separately do a supplementary block of that, then only the skin incision will be taken care. Right? This is how you can see here for a clavicle, all the things are the nerve root values are C5 and C6, and supraclavicular nerve just now I have said. And one more important point is the medial end is much more trouble. So you get crossover fibers or from the spinal accessory. It's just to you hit the bone and try to infiltrate if you're going to tackle your medial side of the clavicle, right? So most of the times we have been scared about this phrenic nerve palsy. It is 100% in interscalene, and you will lose. Yes, it is, but not for young, healthy patients. When the patients are COPD or they're really dependent of your diaphragm, you need to have a blockade here, somewhere here, where these two neural elements divert each other. They, after 1 centimeter from cricoid college, they move almost 3 mm in direction. So try to perform a selective upper trunk with the supraclavicular, where the same C5 and C6 which is involved for your osteotome, dermatome will be blocked, right? So complications, that's why I said if you're going to place more ml of volume in interscalene, you will block your phrenic nerve, then the vagus, so you will have a bradycardia. Then if you're going to put your sympathetic blockade, and will have a Horner's syndrome. And if your patients have hoarseness of voice, your local has already reached your tracheoesophageal groove. Fine? So brachial axillary, I'm just going to say 2 points. Musculocutaneous nerve will not be blocked in your axillary brachial. It has to be blocked separately. Second point is, this is a highly vascular block. Please, you will be landing up in last, so please apply your color Doppler. The third is, you can perform your intercostal brachial nerve block in this very easily, knowing the latissimus dorsi, where it lies, your intercostal brachial runs over the latissimus dorsi, so you can easily place 5 to 8 ml of 1% lignoadrenaline to easily block your this. So next, coming to the lower limb, femoral nerve block, which is one of the basic block for your lower limb. The most important thing is we have to identify the fascias first, which is fascia lata and which is fascia iliaca, then only you have to able to block it adequately. So the points to remember in this is, never ever get any deep branch. Your femoral artery should be single, right? If you are able to get an image, it should be always single. Then you find if you are getting any deeper branches, the femoral nerve would have already divided into anterior and posterior. And if you are going to block only your anterior, cutaneous only will be blocked. And if you are going to block the posterior, only muscular branches will be blocked. Okay, just imagine when the skin incision starts, you will have all the problems here, right? It will be best used for the on-arrival block, but I reserve my word in this. It is reserved only for hip fractures, not for shaft of femur. Please don't put a high volume or high concentration block in a femoral nerve for a shaft of femur. High concentration especially, you will land up in acute compartment syndrome, right? The next thing is, it can be used in preventive block. Most of the times, it is an analgesic block to perform your spinal and epidural, give a block and make the position. Try to add some lignocaine and adrenaline. The moment you give the block, and already one person would have already scrubbed in for the spinal and epidural, and you will pull the patient to sit in, you think that your block is failed. No, you most of the times you do in 0.25. Please do add some adrenaline in that. That will help you as a vascular marker also. So coming to the innervation of the knee, it is quite complex. Even it is very difficult to understand. Even I do have problems to understand this. So how to comprehensively block all these nerves? It's by placing an adductor canal. Most of the time you do for your TKA patients, and where you inject almost finding the mid thigh, 20 ml you try to inject, right? So anatomically this is not an adductor canal. That is what I wanted to implement here. So whatever you have done all these years, it is just a femoral triangle block where something you have to see your sartorius and adductor longus, which is known as a prayer sign. So almost I try to pray to see these two muscles when I do my adductor canal, or the femoral canal block. So I'll just place my needle from anterolateral to block the saphenous and the nerve to vastus medialis. What is then done in adductor canal? What nerves do I block then if I am going to do it? It's only the saphenous nerve. Then why should I place this? That is what is being described by the authors, Karthik Sonavan and Tugin said they are here. So dual subsartorial, what if I combine 10 ml in the femoral and 20 ml in the proximal adductor canal? So I will be able to cover much more nerves, I'll just say you. So this is what we did to identify what really we are doing. And this shows the trunk of your femoral nerve is being not blocked, and this is a site-specific motor sparing block. Agreed? Then you can see some amount of methylene blue dye over the sartorius. It blocks the medial and then intermediate cutaneous nerve branches. This shows it also blocks the cutaneous nerves of inversion. And more importantly, you will be having the subsartorial plexus. This is the sartorius, this is the behind part. Subsartorial plexus is also been involved in this. So that group of nerves is, or I'm just saying this is the subsartorial plexus where you block your saphenous, obturator, medial femoral cutaneous, right? And this peripatellar is nothing but the branches of these. But the authors claim here they may reach the popliteal plexus. But what we really found out, yeah, one more point I just wanted to say is, this is what I'm trying to explain. This is your saphenous nerve. This is the only content of your adductor canal block. This is the only content. And you can see your nerve to vastus medialis, it is not strained here. It's very partially strained. Today you can go and see in your cadavers, it's excellently dissected. The same picture you can able to see there in your cadavers. That runs separate, it is not in your adductor canal. Then why I really wanted to perform an adductor canal when I can achieve with a femoral triangle? Why should I do it? So to reach the popliteal plexus, that is what is our aim. We have to give a comprehensive block, right? So we didn't find, but maybe I do advise here one point. Rather performing in proximal adductor canal, you can try to perform a distal adductor canal. Maybe if I'd have placed my methylene blue little distal, maybe this would have been blocked. That is what is the take home to you today. So last two blocks, I'll just rush it through because of time. You know the rectus sheath, the most important point here is above umbilicus and below umbilicus, whether what you're going to perform. Above umbilicus, if you're going to perform, you have to find two layers or the tram appearance below the rectus muscle and try to place it between that fascias. Fine. Below, be careful, the tram will be there, but if you try to pierce it, you will directly end up into the peritoneal cavity. So below umbilicus, be safe. Above umbilicus is better, you have one more layer there down. Okay? So this is what I was trying to say. If you're trying to say the layers are much more in above umbilicus and below umbilicus, and 90% of your nerves will be there in that tram track, between the tram. But sometimes if you're very unlucky on that day, the anatomical, the things that I showed, so it may somewhat directly pierce the lateral edge of the rectus and may come up. So if your day is not good, you may not land up in blocking those nerves. So our own PG's favorite block, rectus spinae, everyone wants to jump and then puts. So the thing is, the trip and tricks is try to place your needle just at the edge of your transverse process, because these muscles are very adherent to the things. So then only you will be able to lift that muscle, rectus spinae, and you have a good craniocaudal spreads. So there are various amount of level of evidences. If you ask me, I will say this is a very good dorsal rami block. I'll reserve my word for that. And try to use it for your posterior spine cervical fusion surgeries. Place your probe at T1 and try to perform it. You will see magics when the surgeons puts your incision. It's really very good when combined with your multimodal analgesia. climbing off the ventral rami and visceral analgesia, it's yet to be explored much, where I will not give my word in that. Because this is a facial plane blocks, it may vary. So that is the most controversies in facial plane blocks. It's very controversy, you will have inconsistent effect. If all of you going to place erector spinae, you will have different results. So it's a facial plane, so more amount of volume is needed, and you have to use continuous catheters techniques to prolong your analgesia. So if you have been called for a rift fractures, posterior, especially posterior rift fractures, and you try to perform an epidural, I think the time is up, sorry, 25 minutes, 2 more minutes, I'll just finish it off. So if you're not getting your epidural, please don't worry about it. Just take out the needle, perform a bilateral erector spinae plane block for that patient. That will be easy if you're not getting your epidural in the night of call for a rift fracture pain management. But be careful, don't place 0.5 BBOK bilaterally. It's going to be causing much more problems. Very toxic, fine. So last 2 slides, wherever you perform, there are some prerequisites. Please take care of your emergency cart monitors. The last kit, at least have intralipid for at least 70 kg patients. And informed consent, procedural sedation. Always have your IV line while performing. And be calm and quiet, well-equipped block room should be there. And you have to have a good communication with the patient and also with the members there. And apart from WHO, we should have a separate checklist for the blocks. Please don't perform a wrong block at this era of ultrasound. And future directives, I said, is very little. We can talk in one single word. I can say it is AI. What I will say is the future directives is here, why we are here, the regional analysis enthusiasts. And we should perform researches which brings out patient-related outcomes rather than trying to perform novel blocks. I want to learn this and I would learn that. Please be competent in this core A blocks so that gives you more patient-reported outcomes in a better way. And these tools, then why it is so, we can assess the new trainees rather than subjective wise. You can assess them. Now we are in the era of competency based. So I think we can assess them with using all these things. So take home points, know your anatomy, be comfortable with your ergonomics, know your machines, choose the correct dose for the right patient, for the right limb, know your endpoints of scanning. At least please remember this, always apply your color Doppler. Fine. And multimodal analgesia, when I think the next speakers will be talking about that. And follow your ASTRA guidelines for superficial and deep blocks and have intralipid always with you. Thank you. Thank you one and all for your patient listening. And I thank Dr. Serena ma'am for giving me this opportunity. I hope I have done the job. Thank you very much. If any questions, I think we can discuss at the end of the session. Thank you very much.
We had it here in Vellore. Of course, it was a different hall. I think maybe conference may not be in the part. But it's a nice experience. But the town has grown up quite big. Yesterday, it took almost 40 minutes for me to enter Vellore town after coming from Chennai. Then I thought, okay, of mine. There's nothing wrong about it. Yeah, without wasting much time. And once again, I thank the organizers for inviting me for sharing my thoughts about the overview of pain management. And Dr. Serena and Dr. Ekta, two good friends. So it's nice again. Many more new friends are also here. Some old faces. Nice seeing all of you. Yeah, if you just look at the whole thing, like now, my topic is about. I think it's not on. It's like, I think some technical part of life. Don't worry. This is also kind of pain, technical glitches. Like the previous speakers talking about AI, this is our NI, that's natural intelligence. So we keep on adjusting the plugs, and what it's part of life, we accept it. It's not a big deal about, not to get worried about that one. That's not interfere. Of course, before, as they're taking some time to do the corrections and all, my job is to give about the overview of the chronic pain management. Of course, some of the topics might be overlapping with the previous speaker. The pain per se, what is being said is it's it's after the Greek goddess pain actually. Pain per se we define the unpleasant sensory and emotional experience associated with or without tissue damage, so on and so forth. But finally, if you just look at it in simple words, patient says it hurts. What hurts is pain. So why are we discussing this topic, you must be wondering, and of course what's the relevance to today's session. It's time for us to think about all these things, because there is a reason actually. I think here my slide also getting switched here and there. If you just look at the technical aspects, for example, what's the prevalence of diabetes in the world? If you just look at that one, it's roughly about 7%. And how does the diabetes end finally? It can end up like some people might have neuropathy, nephropathy, angiopathy, hemopathy, sabapathy. All pathies keep on coming and all those things. So when having what is the amount of investment, what goes on the research with respect to diabetes? Like you talk of inhaled insulin, or you talk of mechanical pancreas, and so many things and all. And about coronary heart disease, about 6% prevalence. Again, if you just look at the whole thing and all, look at the drug-eluting stents, or probably you have the octopus for surgery, and then this, that, and all those things, so many things, ECMO and all those things. I talk of cancer and all, of course, most of the cancer patients, they're not scared of death, but they're scared of the painful death, to be more precise. And so much work goes on about cancer, like nanotherapy, nanoparticles being loaded, or maybe robotic surgeries. When it comes to chronic pain, it's 26%. That means 1 out of 4 persons sitting here has some kind of pain at some point time or other. 90% human population have pain. And what is the research that goes on? Let me tell very clearly, probably after maybe diclofenac and after that its cousin aceclofenac, we didn't have any analysis, right? So look at the amount of burden of chronic pain, what we have society, about what research is going on. It's not that things are not happening, a lot of things are happening. Probably next 5 years you might see the newer molecules as such. So that is the reason why we are discussing such a common problem. Probably after you finish the CME, you go back home and tell your parents that I attended CME, what did you learn? Something about pain, tell me about my joint pain, how did they solve my joint pain? That's it. You are flat. You are gone for a 6. And you say you cannot give diclofenac, aceclofenac because it causes the more than 10 to 14 days called nephrotoxicity or GI toxicity, and you cannot give opiate because constipation or addiction. Then what do you have? Except for Jandu bomb? So for that, why should we have a CME? So basically, we need to work on that's the burden of pain, what exactly we have to understand. Of course, there are, and my slide, that's not moving here, this is moving. Anyway, something is moving, that's okay, no problem. Of course, these are different kinds of pain. If you just look at it, the superficial cutaneous pain is something like abrasions, what you might have and all. If you talk of the deep non-visceral pain, it's something like back pain. You talk of the visceral pain, maybe abdominal colic. I think I'm going back and forth, I think. Yeah, no problem. If it's a neuropathic pain, I told about diabetes, I told you about that one. Yes, this is most important, psychogenic or functional pain. When do you label it as psychogenic or functional pain? Quite often it happens, see, that his problem, her problem is pain. Otherwise, why will they pay consultation fee and spend their valuable time with you? They have some pain. Like I have somebody, patient, who, like an IT professional, who says, back pain and all those things. I said, when do you feel better? It's a weekend. That means pain is in the office, not in his back. Probably they were used to work from home. Now they're asking to come to what's called that, what is the ROT or RTO, something I read. Return to office, RTO, something. The new word, what was work from home, now it is RTO. Return to office, the company says, and he says, I cannot come. That pain is in the office, not in his back. So when we don't understand, we put psychology, right? It happens in a post-operative ward also. Same surgery, same surgeon has done right inguinal hernia, subarachnoid block again. One patient diclofenac works, next patient diclofenac doesn't work. And why is that so? And you will tell the patient is psychologic. No, it's not like that. We know about we call it as a pain soup. Of course, we are all in soup, that's a different story. But basically what it says, they isolate about 23 to 25 inflammatory mediators, out of which we have on medication for 4 or 5. Maybe paracetamol you can take, or prostaglandin inhibitor, maybe opioids kind of thing, something here, maybe a local anesthetics. Okay, you want to consider steroid also is fine. After that, I said 25. Some people might be predominantly interleukin secretors. Some people might be predominantly complement secretors. You don't anti-interleukin, you don't anti-complement. But do you think that for everybody prostaglandin inhibitor should work? It won't work like that. So naturally, patient feels that I still have the discomfort. So it's more like that. We have to understand science much more than anything else. Of course, acute pain, post-operative pain, what you say, the wound heals, pain goes off. Chronic pain is wound heals, pain doesn't go. I would like to put it that way because time is limited. I don't want to extend too long. Can acute pain evolve into chronic pain? Yeah, it can. Why not? Repeated irritation. For example, if I keep on talking, you start yawning. That's nothing but same. That's a chronic pain again for you. So, cosine, what I'm trying to say is, concentrate. Even if you rub your nose continuously, after 5 minutes it becomes red. So, same thing here. Like our body matrix works like that. But why it should be treated chronic pain? It's very important because it causes a lot of occasional social family dysfunction. People come with coccydynia. They say, I cannot sit and I have to prepare for exam, but I can't sit and read. Imagine coccydynia patient going for exam for 3 hours. He has to sit on a hard bench. It's discomfort, right? It causes, for everybody has their own problem. Extensive, costly, non-productive investigation treatment. People come with big bunch of MRI files. This was 6 months back, this was 1 year back, this was 2 years back, 5 years back. Physical suffering, disability caused, death often by suicide. That I did not know. Actually, this was somewhere reported sometime in, I think 2014 or something like that. I still remember in Hyderabad, 14 people committed suicide because of unrelated chronic abdominal pain. I repeat, unrelated chronic abdominal pain. They left a suicide note and died. They committed suicide. That means what I'm trying to say is, we don't know who's going through what. So it's very important, but most important is world is traveling from invasive options to non-invasive options. Much more simpler. Where we had the telephone which was wired to the wall, now you have the mobile phone in your hand. Now we used to, that's what I was telling my friend, like we used to use the blackboard and the chalk and all those things. What these people are doing? Touch screen. So we are all outdated now. Right? It's much more easier. You can write anything, you can edit anything and all those things. Our teachers used to struggle a lot. And that was a different era, this is a different era. So many things are being tried and explored all over the world and all, but still at the end of the, who the first pain physician in the world? First pain physician. You all know. If I tell the answer, you will say yes. That was Mr. Adams, not Eve, Adams. Because they were the early gatherers or hunters. So they used to get some injury. So they used to put their finger in the running water or some herbs or shrubs, something they were doing and all. And you forget about them. Now, for example, all of you, how many of you have any elder brother or younger brother or sister? Somebody? Raise your hands. Yeah, most of people have. How many times both of you fought? Right. How many times, if you are younger brother or if you are the younger, your elder brother made you to keep the finger behind the door and close the door or window? Either of, see, let's be honest. And because they want to play, they'll make you to put the finger behind the window and they try to close the window. And then once again, you can't cry, because if you cry next time he won't play with you. And if you cry, your mother will come again on slap also. So what you do next one is, it shuts your mouth also, it controls the pain also. But who taught you that by keeping your finger in the mouth, that my pain will go off? It is your innate, which you learnt over years. That's human memory, is what I'm trying to say. So these are certain things which are quite interesting to understand. Of course, time memory it is going on. Now, this is the most important slide if at all you want to remember. It's very important. Probably people who have studied pathology recently, they can remember this one. They're like, no, how the pain pathway exactly. And the primary action, you can just know about this one. I hope it works. Okay, I use the cursor. Anyway, it's okay. So primary. Yeah. No, I don't know. Yeah. Anyway, it's okay. No. So primary activation is basically that's what you like. Remember, Rubel, tumor, dolor, all those things. Probably the sequence events and all. So what happens is, if you just look at this one, initially what happens, it releases potassium ions and stimulates. Sorry. Yeah, it releases potassium ions, and subsequently what happens? The prostaglandins gets at free nerve endings, prostaglandin gets stimulated, and bradykinin comes blood vessel, and the impulse get propagated. Then secondary activation, it goes again some more peripheral nerve endings. The substance base stimulates the platelet, and 5-HTD comes out. Mast cell gets stimulated, hydrogen comes out. So all this cascade keeps on getting propagated and all those things. So this was kind of pain soup. 25 inflammatory mediators have been picked up here. Whenever there is the swelling, what you say, the swelling after the injury, 25. And we have only 5 or 6. So we still don't know work, but work is on for another 20 and all. A lot of new products are coming. And this is one thing I would like to share with you actually. Most of people, you might have seen or heard of phantom limb pain, right? Right? So question here is, sometimes the phantom limb pain patients, when they come, no, they tell peculiarly. Whenever I want to have my foot, my forearm pains. How can it be? This is amputated, the hand is not there. Rest of the time the regular pain is there, but when I'm having foot, the forearm pain, it comes, I start getting the forearm pain. So they kept on thinking, then they did the functional MRI and all those things. This was done by one of our Indian origin person, Dr. Ramachandra Guha, neurologist. And he showed that particular thing. For example, somewhere here, if you just look at this, of course, brain picture, whatever. So where the activity is more, say for example, if you just look at this particular picture, this is this is the forearm, because the entire human body is reflected in the brain upside down, right? You know about that one. So what happened, like, when the forearm amputation happened, like, the biggest real estate agent in the world is your brain. Whenever something is not there, it tries to occupy that place with something or other. Like even if you have a wound also, it tries to cover it. And same what happens when the forearm is not there, the impulses are not coming, the cheek area starts growing into the forearm area. And then what happens, because of that reason, whenever he starts chewing the food, he gets a forearm pain. So they kept on doing for 1 year a lot of rehabilitation and all. Finally, they could segregate both of them away from each other, forearm and the cheek. So a lot of these things are happening. What is like, when you keep reading about these things, you realize so many people are working. Sometimes you might get the end result, sometimes you may not. So it's time for us to think about the principles of pain management. Of course, nothing, you have been doing that one. Treat the underlying pathology. If there is fracture, fix the fracture. Increase the pain tolerance threshold. Like any fracture comes patient, before they can take up for surgery, you have some half an hour time for X-rays and all. You use some medication, pharmacological medications to increase the pain tolerance threshold, or non-pharmacological approach. They say meditation, hypnosis. It's difficult to use it in the acute setting and all. Meditation, hypnosis needs a long-standing practice. Pain pathway inhibition and all, increasing endogenous opioids. That is about acupuncture and all, which of course we are not licensed now. Stimulation spinal cord gate, that is one more thing. Last one is your nerve block. Interrupt nociceptive pathway, that's the last one. And 90% of your chronic pain management happens to be pharmacological. Only 10% requires intervention. That you have to keep in your mind. So you don't have to worry too much about that one. Of course, these are the different areas where when you use the nerve blocks and medications, which are the spinal cord area where it works and all those things, like, at the periphery, you can see the local anesthetic NSAIDs, paracetamol, opiates working, epidural working at the Daughter's route, and also intrathecal and also epidural. A lot of these things are there, but okay, fine. A few words about interventions, interventional pain management. We have, of course, non-imaging assisted interventions, fluoroscope assisted interventions, ultrasound guided, CT guided. Because these days we are all use the navigation also. Those days we used to just go from place to place, stopping the vehicle, asking somebody which is the way to Chennai, left turn, right turn and all. Now you put the Google map and keep on driving. Sometimes it might lead to some other place, that's a different story. But it does happen, so we keep on using that one. Let's look at some of these things. Non-imaging assisted interventions, trigger point injections. Are you subarachnoid block regularly? What you do is non-imaging assisted only. No imaging at all you're doing. You're directly giving this subarachnoid block, and you're getting the effect and you're happy with the surgery. So those things are there. Fluoroscope assisted procedures, especially if you do it for the many of the chronic pain work, predominantly lives on the fluoroscopy earlier. Of course, now the ultrasound has been added. A lot of newer things are there. It's good. Of course, for the SA joint and of course for the facet and all. Yeah, this is something interesting actually. I don't know how many of you have really seen the trigeminal neuralgia, for example. For example, those days we used to use the paralysis technique. This was about 20-25 years back. We used to use paralysis technique. Subsequently, fluoroscopy came. Now you can see the foramen oval. You can walk into the foramen oval. You can select the division. You can do the lesioning or radiofrequency lesioning, whichever you want. This is the foramen oval. This is the foramen oval. Right? The nucleus one. Because I wanted to go for mandible. I wanted to go for optical level one here. And this is actually not. This is a lateral view. This is cylinder shaped. This will enter the foramen oval here. So those days we used to inject, I would like to say, alcohol or phenol over there. But biggest problem is when you inject alcohol, phenol over there, don't forget because the brainstem it just flows like that. So it might. So alcohol can be used for better purpose these days rather than trying to put it in the foramen oval. You can put some inside some other foramen. That will be much more useful. Position, more accuracy. You want to spare ophthalmic and maxillary. You want to go for only for mandibular division. You can do that also. And of course, like earlier, I still remember those days. We used to, in fact, we were the earliest to use the epidural needles in India, 2 needle. I think I used it in 1992 or something. Catheters came later. It was only the needle which came first. So initially it was being tried. We thought it was more like a subarachnoid block. It was the first experience for us. So we used to give single shot epidural. No catheter was available. So for example, the varicose veins, we thought predominantly lower limb surgery. Let's go for varicose veins. So we used to inject. We were all residents at that time. Inject what happened? Right side they want to operate. Left side used to be very well blocked. And right side will be lifting the leg. And we used to we used to feel embarrassed actually. What do we do at that time? It was quite embarrassing for us. We did not know. Now with the fluoroscope and all, if you just observe this one, you just look at it the spine is also, it doesn't come in midline. It comes on right and left. That's why you get spina bifida also. And same thing here also, you get both the roots and all those things. Everything comes on both sides. They come and meet in the midline. If you just look at the contrast over there, where the red mark is there, you can see clearly one path one way, one path one way. So what happens when you put an epidural catheter, bilateral TKR, you put an epidural catheter, one leg is very well blocked, other leg is not blocked. It happens not for your fault, because catheter might coil predominantly right side or left side, because there are so many septae there. So many compartments, epidural space. Epidural space is not like a subarachnoid single chamber or like your esophagus. No, it's multiple chambers. So that's where some pocket, the local anesthetic might go, you might get dense block, some pocket may not go. So that's why many people prefer to do a combined spinal and epidural rather than going only for exclusive epidural unless there is a high risk. And you go for the chronic pain also same thing. For example, if there is a, for example, earlier we were not using the, I would like the fluoroscopy, or teachers used to use the directly blindly make the patient sit and inject the, should say the required medication. But again, if the right side pain is there, the solution goes to left side, patient won't get relief. And you think your procedure has failed, patient also thinks same. It's not like that. Because you did not know where the needle tip was finally. When you started, you know up to from skin. After that, don't know where the needle tip has gone. It will depend only on loss of resistance. So these things were there. So it became with fluoroscopy, it became much more side specific, whether right or left. Subsequently, it will be side specific, but what happens? Like fluid always take path of least resistance. Like for example, if there are two lifts which have come, one lift is full, other lift is empty, you'll always take the empty lift. That's path of least resistance. So here also when you inject the fluid, if there's obstruction, the disc pressing over there, the fluid tends to go to the opposite side where the normal disc is there, normal part of disc. So then we became side specific also and site specific also. That's where you can see the roots over here. Here. It's not only site specific, exact which route you wanted to block. Specifically, that's not only site specific, it's site specific also. Subsequently, of course, we had like a lumbar sympathetic block there, and then ganglion impart block for many of these things. Then lumbar sympatholysis, where we used to do the lumbar sympathectomy by surgical option. Now we are doing with the CT guided one, comfortably blocking the whatever lumbar sympathetic chain is there. It's much different now. Of course, this is one thing, epiduroscopy and all, I used to use, I was one of the earliest to use in India. We thought probably it might make difference the way, for example, I remember those days, maybe when I was doing my MBBS, maybe 86 or something, we used to have the entire list used to be GJ vagotomy, GJ vagotomy, GJ vagotomy. Maybe seniors will remember. Now the list has gone changing. Now it's lap chole, lap chole, lap chole. Now, what happened to all those GJ vagotomies? What happened to those people? If you just look back, you don't know what exactly went wrong with them. But subsequently, what happened when that was being done, then all the ranitidine, cimetidine, everything came, and then we had the endoscopy to pick up whether somebody, all pain abdomen, we used to do GJ vagotomy. Then subsequently ultrasound came, then we picked up the gallbladder stones. So what was gallbladder stone? We were operating the GJ vagotomy. Luckily for us, God is still great because none of them really came back and complained GJ vagotomy patient. But yes, we learned like that. So we thought of using the epiduroscope, putting the epiduroscope in the epidural space and trying to see and all. But no, you can't see more than, I would say, lymphatics or maybe some blood vessels or some fat. And of course, some roots you might see. But of course, now people are doing transfemoral like an endoscopic surgery and a lot of things are changing. But fine, some innovations had to happen. Yeah, this was Dr. Serena wanted me to share with you. Ultrasound guided interventions and all. Of course, a lot of things already expressed by our previous speaker. Better resolution, of course, it's good and all. But it takes practice makes a man perfect. You have to keep on using. Like my children use my phone much better than what I use. I know on off or checking the email, that's over. That topic ends there. But they know all the features and all. That generation, next generation. This was the advantage of ultrasound in chronic pain. You can see the structures directly because in fluoroscopy it's bone or non-bone. You don't have any soft tissues like talking of muscle or maybe blood vessel and all. Provides real-time needle advancement. Risk of radiation is avoided. Machine is transportable. Cost is comparable and can be used for other specialty work also. Limitations are dependent on observer. Bony details obscure the information because in fluoroscopy bone is our friend, in ultrasound bone is our enemy. So that's how it goes. And contrast spread, sterility, learning curve, pre-procedural scans, sentinel axle blocks, 2 performers are required. That's one problem because sterility is one thing. One person holding the probe, trying to inject, somebody to load and all. But of course, I was there sometime in Beijing, I think. I saw a prototype. It was nice. One of the National Congress. Like ultrasound comes, the probe comes with a cup kind of thing. It holds the like suction. For example, you want to tab lock, it goes sticks there. Then your both hands are free. Putting the needle, loading and also. So newer innovations are happening. We don't know when we are going to see those things. It used to be debate, are we getting carried away with the new tool in our hand? Everything comes and all. That was one time, a lot of thesis used to be like, something comes and all. First thing is put intrathecally. And the company says brand clearly, please don't use intrathecally. Anything new molecule comes to India, first thesis will be intrathecal. I don't know who gives that idea to the youngsters, I don't know. But does it really make a difference? Or is it only mental block of not willing to change any modification? Of course, many people felt that mobile phone cannot be used. But of course, that was the only savior for all of us during the COVID time. Earlier, we used to tell kids not to use the phone. But during that, everything they had online class. They were always on the phone. What they were seeing, we did not know. When you come to open that screen of the class, when we go, they watch the movie. This is a double-blind study. You also don't know, your wife also doesn't know what is happening there. So, things happen. But this one actually, it's nice actually. These are the tribe people at Masai Mara in Kenya. These people are also practicing cricket now. They are basically hunters and gatherers. These people also start playing cricket, then what's wrong with you? Why can't you use ultrasound or fluoroscopy for that one? So that's what I just wanted to say. Of course, for back pain, we have been using it and all, of course. Probably as we go for the workshop, I can discuss much more. Some other, of course, ultrasound, first time was used in 1971 in Russia for lumbar puncture. Technology advancement has happened a lot, and a lot of probes are there, a lot of use are there. Of course, about the spine, they wanted me to discuss about, of course, so it's better to use the hands-on over there rather than over here. But you can just see, you can see the spinous process. You can see the posterior dura, anterior dura, spinal cord, anterior complex, and vertebral body. Many things you can see. But again, I'm telling you, it's a practice which makes man perfect. And a lot of thesis people are doing whether ultrasound adds to the benefit of identifying the, rather than taking 10 attempts. Because I'll tell you, biggest problem where happens it is, you do, say for example, I'm talking elderly people doing joint replacement. You go for subarachnoid block or you go for an epidural, whatever you are comfortable. They do an X-ray to understand how distorted the knee is, stage 3, B, 4 and all. But the same patient might be having the degenerative scoliosis also. But you ask for an X-ray spine, you ask for X-ray chest, you ask for ECG, you ask for echo. Do you ask for X-ray spine? Only thing you know after skin is going to bone. Which part of the bone? It is transverse process, lamina, or is it a spinous process? There this might be of useful for you. Because if you want to, you can just bedside, you can just check which is my path of least resistance, bone-free window. That's all you have to know about that one. And again, of course, you can see the different views about the lamina and articular process and also. CT guided B I use quite extensively because for me, I get the combination both of the soft tissue also and a single picture I can get. This is of course celiac pressure block, what we do for the abdominal malignancies. Of course, radio frequency ablation is one thing which has come, like something electrocautery. Spinal cord stimulation, which is there for quite some time, 1960s onwards it's there. It's doing only the cost is little prohibitive, but things are changing now. It's a matter of time. Right now it's costing anything anywhere between 10 to 12 lakhs to go for that. It's something like pacemaker. Pacemaker controls the heart. This one controls the pain signal. The intrathecal drug delivery system for especially spasticity patient, like we use the baclofen pumps also, or maybe sometimes opiates also we use for cancer patients. Of course, some of the advanced neurosurgical interventions are being done, are being planned. Some are given up actually. Percutaneous cordotomy, deep brain stimulation is being done. Tracheotomy, thalamotomy were quite popular at that time, but quite invasive. So, being given up. Last 1 or 2 slides, I think probably. The benefits of the interventions, of course, there are non-ulcerative benefits like limitation of side effects, improved quality of life. But only one problem is weight gain, which is quite common. Pharmacological methods that may not be there. Less sedated and alert and satisfied patients will be there. A combination of medications and interventions will be best option. Meaningful expectation of patient, whether he wants to become all right or he wants to stay in the hospital because company is paying for his bill. That's also equally important. Imaging assistance definitely offers a lot of difference. A lot of newer things are coming, a lot of associations are involved in this kind of management. But the only thing is don't go with the half-hearted thing. Like, you are giving your child a very good life jacket to save herself, but you see yourself what you have done. You put the Coke bottle. So you not only you sink, along with your daughter also will sink. So make sure that don't go with half-hearted knowledge. Pain is one of the most common reasons that people seek medical attention, needs to be managed adequately. Use combination of drugs to target multiple points. Multimodal management is the best option. I think we have one more lecture on that one. Well, this is what actually we started as ape in our life, and then of course subsequently became early man, then stone man, iron man. This is what right now, and we thought finally, that's it. We thought we'll get the much more Superman, but we got the Coke man. So let's not do that one. And of course, the lower one is not actually the Hyderabad Pulse. It's not Hyderabad Pulse. Actually, the project where I am involved, it consists of local anesthetic, opioids, and then paracetamol. Okay, and everything coated there, everything. And when you open the abdomen, when you're closing it, you just put that mesh kind of thing, close it. Because the pain is in the abdomen. So why do you want to give oral analgesics to the patient? For local pain, local solution. So it doesn't cost much, but we're working on that. If that helps, life becomes much more easier. You don't have any gastric symptoms and all those things. Pain is in the abdomen, treat the abdominal pain. Why do you want to go for something else? With these few words, I would like to thank the organizers once again. Thank you so much. Have a good day.
Good morning. I first like to thank Serena ma'am for this opportunity. So, for the next few minutes, we'll just together look at the neurobiology of pain and also look at a few recent advances in relation to understanding the biology of pain. Just like how Sir had said, pain in fact is the most primitive and widespread human experience, and though many of the terms were established in literature, the following pain terminology actual or potential tissue damage. Let us quickly just look into historical milestones very briefly. I think it's important for us to also acknowledge so a brief timeline of the historical milestones in the field of pain therapy. Morphine was first extracted in 1806, which opened the chapter in fighting with pain using modern medicine. And this was followed by Dr. Felix Hoffmann in 1897, who synthesized and proposed the use of another representative drug, the acetyl salicylic acid, also called as aspirin. This was followed by a very important milestone, which was the proposal of the gate control theory of pain. And this is what provided novel information on the modulation of pain and thus the clinical pain management. And following this, just few years later, all right, and we had this led on to interventional methods such as spinal cord stimulation, identification of receptors involved in this, as well as invention of intrathecal opioid delivery. And 4 decades later, we have now even the first monoclonal antibody therapy, which in fact uses interleukin agonist against interleukin receptors. Gene therapy, the first trial in fact was targeted for pain related to rheumatoid arthritis, where they used HSV based vectors, basically herpes virus, and they incorporated the human gene of interest, which was pre-enkephalin, and it was actually showing beneficial effects in treating focal pain. Now, leading on to, or say concerning diagnostics, in fact, pain therapy was one of the first fields to in fact employ AI. And they in fact did the first clinical application of AI, where the study showed that it was superior to clinicians' diagnosis in providing differential diagnosis. And 7 years later, it was Dr. Robert Edman who utilized MRI to understand the brain activity by neuroimaging. And so now we have come to use organ-on-chip models. In fact, even the first IPC models, which are basic pluripotent stem cells that can become anything, they've been able to differentiate it to acquire a nociceptor kind of a morphology. Microbiota, there's a lot being heard about microbiota, I'll come to it shortly. And the latest milestone being the brain cell atlas, which described using multi-omics using single cell levels to study various pain mechanisms. So the literature reveals that there is no single widely accepted classification system for pain, particularly for cancer pain. And several classification systems have been developed. The IASP classification system have broadly put it into nociceptive, neuropathic, as well as nociplastic, which used to be, the older term was central sensitization. So what is nociceptive? Anything that involves a non-neural tissue where there is actually a threatened or an actual damage, and is the most representative subtype is the inflammatory pain, where there is involvement of your nociceptors. And if there is lesion involving a somatosensory nervous system, that is called as the neuropathic. And this, however, is more related to chronic disease. The pain is more persistent. It's actually, the response to analgesic is not as great as compared to nociceptive pain. And if you have an actual or a threatened tissue damage, but there is no actual and there is altered nociception, that comes under the umbrella of nociplastic, and there are various subtypes of that. I'm not going into details of that though. So let's just try and understand the basic circuitry of pain. This is to just provide context for the subsequent information that I'm going to provide. So, if you look at the cutaneous sensory neurons, that is the DRG, the dorsal root ganglion, they are activated by a variety of stimuli. And these project onto the spinal dorsal horn. And if you look at this dorsal horn, it has in fact 10 laminae, of which 6 of them are rexed. And if you look at the fibers that carry pain, we know those are the C fibers as well as the A delta fibers. And this division and terminologies came based on the size of the fiber, the myelination, the ability to conduct the perceived pain in the sense here. So if you look at it, you have the it's all right. So you have the C fibers as well as the A delta fibers. So if you can see, those are on top, and those have a preference to the superior laminae as well as there are portions of C as well as A beta. I'll come to what is their context. They have a preference. They're preferentially located in the lower laminae. And besides this, you also have neural projections. Okay, so these projection neurons, which in fact take the information to the brainstem, thalamus, and then to several areas in the brain which are implicated in sensory, discriminative, as well as emotional sensory perception. Now let's just quickly look at pain receptors. So as I said, you have these pain receptors, they go to the dorsal root ganglion and then they reach the brain. So these are basically peripheral terminal nociceptors, and which have actually different kinds of ion channels. And it's very important to know what, because it's the modulation of these that have led on to the target therapies that are being talked about. So these can perceive external stimuli, can code signals, and can generate the excitability. That is basically the action potential, which is pain perception, which is carried on to your posterior cortex. So according to the precipitating factors, they are generally divided into voltage gated as well as ligand gated channels. All right. So from here on, I will give some clinical context. It won't be purely physiology. So there are a number of voltage gated receptors. Okay, one important thing to remember is the, is it possible to get this working? All right. So you have the voltage gated sodium channels, you have the voltage gated calcium as well as the potassium channels. And if you look at the sodium channels, there are various subvariants. And it has been found out this is mutation of this particular variant, the 1.7, in fact is what is responsible for a number of pain related diseases such as inherited erythromelalgia, paroxysmal pain disorder, and in fact this has been exploited where they've seen in rodent models that use of aryl sulfonamide can in fact target these channels. So just few days back, the FDA had approved, and this came all over the news, of the first non-opioid treatment for moderate to severe pain. This was the suzetrigine. Okay, so what does this actually do? What it does is it inhibits the sodium 1.8 and it keeps it in a closed state. So if taking you back to your first year in MBBS, so when you have a synapse, you have an excitatory synaptic potential as well as inhibitory. What is responsible for an excitatory is the influx of sodium and calcium. What is responsible for your inhibitory is the efflux of potassium and entry of chloride. So basically more positivity, excited, more negativity, hyperpolarization and inhibited. So what this drug actually does is it keeps this particular channel in an inhibited state, and it is actually shown to be beneficial, and it's come out in the market. So now coming on to the other ones, we also have the calcium voltage gated channels, the potassium, and as I said, potassium, it basically inhibits. So if you activate its exit, it will actually alleviate or reduce pain. What are the other things? We have the transient receptor potential vanilloid channels. In fact, the Nobel Prize for this was first awarded to David Julius, who discovered this in the first clinical trial in its phase 2 is the use of its antagonist, the V116517, which is shown to be beneficial in post-herpetic neuralgia. The other receptors are, you have purinergic receptors, you have ion-sensitive channels, and exploring the glutamate receptors. There are various subtypes, few which do stimulate, few which do inhibit, and a lot of drugs, and there's one in the market called as the phenobam, which actually targets the type 5, which is an antagonist to it, therefore elevating pain. So as I said, you have voltage gated and you also have the ligand gated. Ligand gated is nothing but it basically influences your secondary messenger system, and that has also been implicated in pain effects, the release of neurotransmitters, and therefore the inflammatory response and the pain related to that. So this A delta and the C fibers, okay, these are the fibers responsible for carrying pain. So they, from their receptors, go reach into the through the dorsal root ganglion, which is considered to be the first order, and in the dorsal horn, they synapse to give rise to the second order, all right, and that goes up to your ventropostal thalamus. Okay, if you were talking about sensations from your head and neck, it's the ventropostomedial nucleus, and that reaches the postcentral gyri of the somatosensory cortex. This is also referred to as a tract of Lizard. So now just a little bit on analgesia. All right, so we have a lot of inherent mechanisms in place. So we have endogenous opioids. You've heard about all these natural ligands which have a preference to specific opioid receptors. And as I said, the mechanism is just potentiating the normal physiology, which is you either increase IPSP or you either decrease the EPSP. You also have a lot of descending pathways which modulate the pain. So you have them originating from the neurons of the periductal gray on through to finally come down and modulate through interneurons onto the main synapse at the dorsal horn, therefore reduction of the pain transmission. So we've all heard, so Sir even said, when you have sibling rivalry and your finger gets stuck, the first thing you do is you put it in your mouth and you press. So why so? So what is the first thing that happens once you jam your foot or you jam your finger? Besides the fact that you know 14 other languages at that point, is you apply pressure. All right, so why do we do that? Okay, so as Sir said, that's an innate mechanism. So basically when you apply pressure, you have these A beta fibers which are not at all related to pain. Okay, and they come and influence these A delta and C fibers. So those fibers come, they synapse with the interneurons which secrete opioids which block the channels responsible for causing an excitatory postsynaptic potential, or they further stimulate those channels which are responsible for causing an inhibitory postsynaptic potential, and therefore finally the transmission is reduced. So that's called as closing the gate, which has been opened by A delta C is closed by A beta, and therefore is referred to as the gate control theory of pain. And this small body of information has been exploited, in fact, in the field of pain therapy. Let's just quickly, very briefly, I'm going to say what are the molecular mechanisms known in pain modulation. So there are a lot, there was a lot of body of information. I just took out some relevant things. As I said, again, you have these voltage gated channels. And there are various genes, if they are being mutated, okay, they could be either a loss of a channel or they could be even upregulation of a channel. And it is seen that it has been specifically correlated to specific diseases. So loss of sodium 1.7 has been related to the congenital insensitivity in pain. And even the disc herniation of pain, when those subsets were further analyzed, they saw that this particular mutation proportion was higher in such patients. And also familial episodic pain syndrome. The trigeminal neuralgia, you have a few who do not actually respond to pregabalin. They've found out that there is a particular mutation of the sodium and calcium channel where it's actually, they do not respond to treatment. And there was also a publication on a few people who actually do not require opioids during childbirth. And when those were subsets were evaluated, they found that in fact it was a mutation of the potassium channel which actually helped them bear the pain better. All right. So that has been, there has been now gene strategies to take in the cassettes which can actually stimulate this particular voltage gated channel, so therefore they can tolerate pain better. Moving on to epigenetic modifications. What are epigenetic modifications? So these are basically modifications or mechanisms that modify DNA or histones without affecting the sequence of the DNA, and therefore you have its downstream effects, which is either addition of a methyl group or a histone group or use of non-coding RNAs. So what global data has shown is there are some implicated main pathways, the DNT, the TET, the HAT, and when these are blocked, these can actually elevate pain. Another major field being studied is the field of inflammasome, where they've seen that this main pathway, this is called as the NF-kappa, I'm sure you would have heard about this, the NF-kappa B pathway. So when you have particular ligands that bind to their receptors, they cause activation of this that goes into the nucleus, and what does is that causes the assembly of an inflammasome. And this causes release of caspases, which cause maturation of the pro-inflammatory factors, which finally cause death or excitability or immunoactivation, or even your brain barrier is being affected. And these processes are what collectively contributes to the hyperalgesia that is experienced following an inflammatory type of a pain. So all of these have now been targeted for pain relief. Another important molecular mechanism that's being exploited is the post-translational modification. This is nothing. So once you have a DNA, you know that it's finally going to translate to cause a protein expression. And so when you affect or you target these mature proteins, since they're already in their mature forms, your response will be much faster than targeting the primitive DNA forms. So these are just chemical modifications. There have been around 600 such modifications being identified, and they have been used as tools to evaluate as well as treat pain. There are also several signaling pathways that have been implicated. In fact, a trial which targeted osteoarthritic related pain, which utilized Lori-C-Wnt, where in fact it targets the Wnt pathway over here, okay, responsible for the joint or musculoskeletal pain. It just blocks this pathway, and then they've seen that it has a half-life though, it has caused a temporary relief of pain for such patients. Lidocaines and opioids, how they also act is they target the MAPK signaling, and you have many such signaling pathways which are now being modulated and targeted. I'm sure you've heard about a lot of research going on microbiodata, your normal gut microbiodata. All right, and so if you look at this picture, I know it looks a bit too much of information, but just know that it is divided into two. So you have the pain induction and as well as you have the pain relief. So there are a lot of metabolites in the microbiota which actually do the same thing, which stimulates pain. And you also have liposaccharides released from E. coli and salmonella, etc., which actually cause pain induction. But you also have flagellin, which produces factors which reduce the sodium influx and which in fact inhibits the vanilloid receptors, the inflammasome. And so all of this has been used now as a target for pain modulation. So if you look at pain relief, okay, you have traditional methods which is still being used now, non-opioid opioid options as well as therapeutics. You have exploiting the control gate theory, neuromodulation, even microbial interventions to see if it can modulate pain. But more recently, you have a lot of research now being targeted using gene therapy, using monoclonal antibodies and stem cell therapy, where monoclonal stem cell more in the preclinical phase. But gene therapy, I just did a quick search in the clinical trial registry. Up to December, there are in fact 16 trials registered targeting different types of pain. So what this basically, it's very easy. What they do is they just take a virus that is engineered to carry the gene editing systems which encodes your specific target genes, that goes into the cell. and that influences various mechanisms that upregulates the specific channels which will alleviate pain. And it's easier said than done, but they've employed a lot of agents. They've tried out different kind of cells. They tried to target immune cells also to see if it can reduce pain. So regarding animal models, there is a lot of papers on animal models trying to understand pain, but the problem is very difficult for us to explain the pain that is experienced by the animal. So there are physical damage models, there are chemical irritants that can in fact cause a specific disease model that you want, psychostress, and all these combinatory composite models are also in place. But however, still trying to make inference based on this has always been a major limitation. So in this field, though there is a lot of work on the mechanisms, and there are a lot more to be discovered. So that is actually in fact one of the limitations and drawbacks, as I said, with use of animal models. And one thing that has not been used up to its maximum potential is the use of single cell analysis, namely the omics techniques. And so therefore translation has been a problem, and pain is more a complex disease. So it's very difficult when it comes to using this. So people are looking at how they can try combinatorial therapies to target pain. So if you're looking at what is still there, and something that all of us can look at is use of culture models to study pain, use of multimodal diagnosis, multi-omics, as well as comprehensive strategies to make use of biomaterials which can cause sustained release of your agent of interest, immunotherapy, in the field of pain modulation. Thank you.
Am I audible? Am I audible? Yes. So good morning everyone. It's an absolute pleasure seeing a lot of familiar faces, and it's a pleasure to join CMC as a faculty for this CME and workshop. I thank Dr. Serena and Dr. Ekta, and it was absolute pleasure coming here as an examiner for the past 2 days for their regional fellowship program. So I enjoyed whenever I came as an examiner for the fellowship program, I really enjoyed the program, because more than asking questions, it was good to interact with a lot of people whom I know here. So I really enjoyed those moments. Dr. Serena has given me a very short time, and she's very strict in the timing, I think. So I'll make sure that I finish on time. Okay. So I have a luxury of the last but one speaker, so I can exclude a lot of slides because there's a lot of overlapping of slides. So I would like to skip a lot of things and make my talk more clinical, so that it might be a little bit more interesting. Slide is open. Okay. So my topic which was given is multimodal analgesia in acute and chronic pain. So when we, I had a lot of slides on the definitions, but already Murli sir has discussed it, and Dr. Elizabeth has also discussed about that. So I wouldn't like to go into the definitions, but what I want to say from these definitions is, instead of going into IASP's definitions of acute and chronic pain, we have to understand one thing. It's not about pain is not only about definitions, but you have to know that IASP also said pain is a sort of experience, and what the pain as perception is what is, for me, is different from what Joseph has. So it is quite an experience. So when we come to multimodal analgesia, the name multimodal itself defines that you choose a mechanism. It's okay? Yes. Okay. So I'm skipping those slides. So what is multimodal treatment? So that means you choose when you choose a concurrent use of therapeutic intervention, which has a mechanism of action which is aimed at different pain mechanisms. So this is what is the definition of multimodal management. Now, when it comes to WHO ladder, I hope like in the recent days you would have seen publication adding the fourth ladder, isn't it? In the WHO ladder, you have a fourth ladder coming into place. So what they've basically done is they've split the step 2 into two parts, and they've added step 4 as minimally invasive treatments. So that is the addition which they have done, and you can see a lot of non-opioids being added along with adjuvants these days. So these days it's a big fancy, like as you know, like for youngsters. So because of the more and more like frequent usage of ultrasound has creeped into many departments, everybody has a tendency of putting needle because it's very fanciful. If you don't put needle, then you're not an anesthetist. So that's the thing which is creeped into anesthesia these days. Yes, of course, we have to use those technology for the benefit of the patients. But what we need to understand is we need to understand the pain mechanisms, and we need to also know that needle is not the answer for everything. So putting a needle is not the answer for everything. Rather, we have to understand the pain for each and every surgery separately, and we need to also review the best evidence possible for that particular surgery and for that particular patient. That's what I want to give more importance. So when it comes to step 1, you see many times the bigger problem is inadequate dosages, isn't it? So when you see for the mild category pain, you see the normal dosage which you usually use 0.5 to 1 gram every 4 to 6 hourly. And if you see the post-op notes, whether it is oral or whether it is intravenous, many times you can see the residents writing injection paracetamol 1 gram, IV 12th hourly. When your half-life, when the action itself is going to stay only for 4 to 6 hours, we cannot write a post-op order where you write 1 gram of paracetamol for a patient weighing more than 50 kilograms as a 12th hourly dose. That becomes completely inadequate. That is not evidence-based. When you come to step 2, now these are the guidelines for prescribing NSAIDs in adults. Now, when you see the choice of NSAIDs, which is being given by either Prospect or Astra, you see these are the GI risk factors: age more than 65 years, previous GI history, concomitant antiplatelets, serious comorbidity, and long-term usage. So these are the cardiovascular side effects. Now, when you have these 2 risk factors, what does and all these 3 factors again come? When you have both the risk factors, both cardiovascular and GI risk factors, then you either have ibuprofen or you add paracetamol along with that. So this is what is the guideline about NSAID choice. Now, when you come for the post-operative pain, as I already said, review your gastrointestinal risk factors and your cardiovascular factors. And as I said already, the first choice is NSAID. If oral route is not available and patient doesn't tolerate it, then you can go for IV formulation. As I already said, do not prescribe diclofenac per oral, IV or per rectal as the first choice in your patients. That is not evidence-based. So when you have a breastfeeding patient, then again the first choice is ibuprofen. Second choice naproxen. So nowhere you have ketorolac or diclofenac coming there. Pregnancy, again, better not using NSAIDs in the 3rd trimester. You can use ibuprofen in the first or in the 2nd trimester. So when you come to second step, weak opioids come into place. Now this second and third step has weak opioids in the second step, and third step they have added oral strong opioids. So this is a basic difference in the choices in the WHO ladder. Now when you see that, again oral dosage has been given much importance in the guideline. So tramadol at a dose of 50 to 100 milligram every 4th hourly. Please see that timing, every 4th hourly. So even if you give suppose you even give a intravenous formulation, still you have to find somewhere between 4 to 6 hours. So inadequate dosing is one reason why your patient has inadequate analgesia. And when you have a usual dosage and the patient has still the pain doesn't settle down, then you go for oral morphine. That's what they say. Now, this slide might not be so visible, but these are the adjuvants which are used commonly, because you see in the WHO ladder, again, adjuvants are being added along with paracetamol and your NSAID. So you see dexmedetomidine, you see clonidine, you see anticonvulsants being added, you see NMDA antagonists. Now, because of the recent incidence of recent epidemic of opioid overusage, a lot of adjuvants are being added by the WHO. So more and more adjuvants are being added in the acute pain in your patients. If you go to your pain clinic, see just one patient coming with CRPS, with swollen hands, surgery being, they had a trauma. They come, say for example, 3 or 4 months later with their skin shining, with lot of swelling and constant pain in their hands. And if there is a scoring system for that, isn't it, for CRPS. So if you see those patients, it's very difficult to treat CRPS. But if you, just one addition of this ketamine can definitely prevent 50 to 60% of patients going into CRPS. So so it's not about only starting the NSAIDs and forgetting the patient. It's about going again for de-escalation. This is called reverse pain ladder. This is again introduced by WHO in the recent days. So what they have basically done is, so once your patient has good analgesia and the tissue damage slowly reduces, it's getting healed, then what you do is you step down your analgesics. So they go from step 4, 3, 2 and 1. So that is how they do. So this is called, so again from PCA, from epidural, from LA infusions, they come back to strong opioids, they come back to weak opioids, and they come back to regular paracetamol. So this is called reverse pain ladder. So don't forget to get into this step so that patient doesn't go into any sort of opioid abuse. Now, what about post-operative? What is the evidence about post-operative multimodal analgesia, with especially non-opioid analgesics and techniques? So this is a review. You can see there, this is published in JAMA. So you can see regional, they have clearly said that regional analgesia, acetaminophen, your NSAIDs, your gabapentinoids, tramadol, lidocaine, NMDA antagonist have been shown to be effective adjuncts to narcotic analgesics. Now, in the recent days again, WHO ladder and most of the guidelines say that opioid has become a rescue analgesic. Opioid is not a first choice analgesic. Now it is becoming a rescue analgesic. If you get this point from this lecture, I think you got the whole point what I'm trying to say. Opioids should be your rescue analgesic in the current era of multimodal analgesia. So see, we have to understand that multimodal analgesia is not a new concept. It was introduced in 1993 itself. It kept evolving. Now it has evolved up to a point where it has become, because of higher incidence of opioid epidemics all over the world, people like governments have given a lot of importance to adjuvants. So on conclusion, JAMA says that multimodal analgesia is readily available and its evidence is very strong to support its efficacy. And surgeons and also anesthetists should use this effective approach for patients using both ERAS pathway or non-ERAS pathway to just obviously reduce opioid consumption. Now, when you see the enhanced recovery pathways in Mayo Clinic, again, they also stress the same thing. Only thing which they've added is preoperative education about your forthcoming pain. So they counsel the patients who are coming for any surgeries, and that preoperative education itself, or counseling itself reduces so much percentage of their pain. So minimally invasive surgeries, regional anesthetic techniques, and obviously multimodal opioid sparing pain management, early feeding and ambulation. What I wanted to stress here is you identify your patients who are at high risk for post-operative pain. Again, I repeat, you identify the patients who are at high risk for post-operative. Yeah, these are the predisposing factors. You can see here. So younger patient, female sex, obese patients, patient who has a history of smoking or pre-existing pain, or patients with anxiety, and the duration of surgery. Obviously, we cannot prevent this. When you have a bad surgeon in place, then duration becomes inevitable. And the presence and intensity, please note this point, the presence and intensity of acute postoperative pain. See, this is a very significant risk factor for those who go into persistent pain after surgery. And worse pain at the surgical site on the day of surgery has been reported to be a significant predictor for persistent opioid use for over 6 months. So if you have a high risk group like what has been shown on the slide, then you intervene for those people. Especially these are the target group where you need to intervene with your multimodal analgesia and make sure that they don't end up with persistent pain. So these are the predisposing factors. Now so as we go into multimodal analgesia, my point is, see, you cannot experiment the whole multimodal analgesia to all your patients, because it has been found in most of the guidelines that all your like WHO ladder or your expert opinion on your analgesic technique, you might be very good in ultrasound guided technique. You might be very good in having a very good analgesic regimen, but that is not the best evidence for that particular surgery and for that particular patient. So what has been clearly said is procedure specific post-operative pain management. You know that. I think most of the consultants know that. That's called prospect. This prospect has the best evidence currently for, so at least 15 to 20 surgeries are there where RA-PM has collected the best evidence. So they have done a systematic review and network meta-analysis. You need to know what is network meta-analysis, and based on that they have recommended for a lot of surgeries. So what you need to do is, I just wanted to say about 2 surgeries so that you know the importance of multimodal analgesia. Number 1 is the highly controversial cesarean section. Okay, so what I wanted to say about cesarean section is, you can see the study design there. Now these are the guidelines. So when you come to the prospect guidelines, you can see the first step, as you know, the first step is understand one thing. If your institution practices spinal anesthesia as the first choice, what is the usual additive you put in your local anesthetic for cesarean section? Yes, morphine. Accepted. Then you're practicing what prospect actually says. What is the dosage? 100 mics. Fantastic. Because if you exceed more than 100 mics, it says more incidence of complications can come. So 50 to 100 mics is the best analgesic regimen if you want to add morphine along with your local anesthetic. And please understand one thing, if you add morphine, prospect says that you need not do any sort of invasive blocks like tab block, quadratus lumborum block, nothing is required. All that you require is, after your delivery, you also add grade 1. What is the grade 1? Paracetamol, 1 gram. Number 2, giving one more drug, anti-inflammatory drug. Adding IV dexamethasone. You give a dose of 6 to 8 milligram of dexamethasone. Okay, that is there included in the prospect guidelines. You can see IV dexamethasone. That if possible, like if some postgraduates are there, I would encourage you to go and take this topic. Give us spinal anesthesia for your cesarean patients with and without dexmed. See the duration of, see the density of block, see the postoperative duration of analgesia. It will be significantly higher. And if you see the emesis, see, it's not only for emesis, it is for the anti-inflammatory effect and for the prolonged duration of analgesia. So this is the reason why IV dexamethasone was added for cesarean section. So once you add that, and if your surgeon is okay, please understand one more thing which is important is the surgical technique. Surgical technique is, if you know, like most of the OBG, people put a finance steel incision. But what prospect says is to go ahead with Joel Cohen incision. Joel Cohen incision means draw a line between both the anti-superior iliac spine. 3 centimeter below that, you put a straight line incision. That will reduce lot of pain in the patients because most of the muscle will be splitted and most of the sensory nerves will be avoided. So this is called Joel Cohen incision. And tell your OBG physicians, OBG surgeons, not to close the peritoneum. Not to close the peritoneum. But the bigger problem is, since the guideline came, I started to convince the OGCians. What happened is, they obviously, you know, they wouldn't get convinced. So you'll be trying to convince, and you will see the next guideline itself will come there. Okay, so they will be completely not be convinced. So you say that what is the best guideline for that, and ask them not to close the peritoneum, and ask them to go for this alternative incision. So once you give this local anesthetic infiltration along with multimodal. So why I want to put this guideline is adding epidural morphine, local anesthetic, morphine along with local anesthetic. Even if you're using a CSE, they would have given you the dosage there, 1 to 2 milligram or sometime even up to 3 milligram. And if you include you can see that the last part of analgesic adjuncts, you can see TENS there. It is strange to see TENS coming for postoperative pain. So such is the importance of multimodal analgesia in the recent guidelines for cesarean section. Now, the next one is for TKA. So most of you will do total knee replacement. Again, I don't know how many of you use this regimen, like how many of you start preoperative NSAIDs in your patients posted for TKA? Good. So if you add 1 dose of oral celecoxib, so celecoxib went and came out, and still now it has been included both in NICE guidelines. If you go to UK or any European country, they use celecoxib, oral celecoxib, 200 milligram. In our country, it comes under the brand of Celebrex. So if you use 200 milligram of celecoxib, it is good enough. And on the postoperative scenario, what you need to do is, you need to put celecoxib 200 milligram morning and night BID dose for 6 weeks. So this is the recommendation which is given by prospect. Now again, understand one thing. You can see, like giving NSAID, giving COX-2 inhibitors, along with your regional analgesia. What is that? Adductor canal, single shot adductor canal administered either preoperatively, along with your cocktail, intra-articular cocktail. So whichever cocktail you can, like either Ranavat or modified Ranavat, anything can be followed. Along with, again, dexamethasone comes into play. You can see IV dexamethasone is there, 10 milligram. And you can see, again, intrathecal morphine has been done. And final point is opioid. Can you read that point, please? Can you read that point? Opioid should be used for? Please don't use IM morphine or IV morphine or PCA morphine, okay, as your first choice analgesics in your TKA patients. So not only about this, so you have guidelines for each and everything. Review all the guidelines. I'm not saying this is the one you should follow. You always modify it according to your institution, and whatever is feasible, you can go ahead and do the protocol according to your institution. So this is has already been told by Dr. Elizabeth, and as you see, like if they see the incidence, the chronic postoperative pain, the incidence is between 10 to 60%, and you can see this is all been already discussed. And you can, if you see the numbers, if you see the numbers, it's alarming, the incidence of postoperative pain. You can see the incidence of patients reporting as postoperative pain ending up with persistent pain. You can see, like in the inpatient setting, patients with severe pain is almost 20%, and extreme pain is almost 12%. So even in the best centers, patients around 30% suffer from severe pain, severe to extreme pain. So most of the analgesic regimens doesn't represent these patients, So these are the factors why patients go into chronic persistent pain. So in the recent days, as Murli sir said, a lot of non-pharmacological methods has been introduced. So and that has to be definitely be added. For TK patients, again, if you have a predisposing factor for chronic persistent pain, my suggestion is to add tablet pregabalin 75 milligram. If you see prospect guidelines, they don't recommend that. But in our institutional practice and in our institutional experience, adding 75 milligram for at least, we start from pre-operative period and add for almost 2 weeks. That definitely prevents a lot of persistent pain in patients undergoing TK. So what is the best approach to prevent acute pain progressing to chronic pain? Number one is your surgical techniques. And number two is identification of patients who may be prone to develop pain after surgery, as we saw the predisposing factors. Number three is have an aggressive post-perioperative analgesic regimen so that your noxious stimuli will be reduced and so that these patients doesn't go into central sensitization and end up with chronic persistent pain. Now, last slide, I think. What are the drugs with the best evidence to prevent this transition from acute to chronic pain? Now you can see here, whatever we talk as big blocks and big regimens have very limited data. I can show the references later, because still lot of regional nerve blocks which we do has not been proven enough, has not been shown. It is very good in the acute setting, but it has not been shown to prevent persistent pain in the post-operative period, or this transition, the patients going into transition pain, they have not found much evidence with local or regional anesthesia. NSAIDs, again, COX-2 inhibitors, they say it doesn't have much effect. Ketamine, it has good evidence, yet it needs more validation. When you come to neuropathic drugs like pregabalin and gabapentin, yeah, promising results are there, especially in spine surgeries, but yet it needs more evidence. So when it comes to opioid, again, there is very, very limited evidence for that. But again, when you come to multimodal analgesia, that's not the answer. That's not the answer, again, for this prevention of persistent pain. But it reaches a lot of, only individual RCTs are there, not much meta-analysis or reviews, systematic reviews are there for that. So as currently to say, multimodal analgesia is not the answer for all our questions. This is not the answer for all our problems. But with the current best evidence, multimodal analgesia seems to be the answer currently. So let's not forget to follow this multimodal analgesia for all our patients, especially let's practice this patient-specific and surgery-specific. So these are the references for the previous slide. So what is the take-home message for my whole presentation, for the topic is, you can see this one. So when it comes to administration of multimodal analgesia, be it in the acute scenario or in the chronic, like prevention of chronic pain, you need to have a biopsychosocial model where you need to give a basic analgesics, you need to give regional anesthesia, you need to give your opioids as a rescue analgesic, and rehabilitation, adding adjuvants, and along with CBT, cognitive behavioral therapy, and all the integrated therapies. So when we practice all these things, I think we can definitely reduce opioid consumption and opioid related adverse effects and possible reduction in the incidence of persistent pain after surgery. Thank you.
A very good morning to all of you. I'm so privileged to be here. Since I've graduated in the 90s from Vellore, I've never been here, and so it's really, really my privilege to be here in this institution, and such esteemed institution which taught me a lot. I'm so privileged also to be part of this anatomy classrooms. The classrooms look much, much better, and distinguished faculty, and thank you for Dr. Serena for inviting me. It's just happened by chance that I was actually invited to visit the physical medicine rehabilitation department, and so I was going to do some workshops later today. So this just happened by chance to be here, and thank you so much for what has been said. I won't touch, I'll just be very brief with certain things because a lot has been said, and like Dr. Prem Kumar had mentioned, there's a lot of overlaps with what I'm going to talk about. So transitional pain, as we all know, that's this chronic post-operative pain which just persists. Normally 1 month, 3 months, and 6 months is what at least we tend to follow as per Medicare guidelines in the US. So if pain persistent for more than 1 month, it's progressing to subacute or persistent pain, because 30 days patients having acute pain within the 30-day period, that would be managed by post-operative surgeon, by the surgeons themselves. A lot of times I get referrals from surgeons, particularly orthopedic surgeons and general surgeons or even gynecologists for post-operative pain, and then they would say, okay, can you please manage this or do some interventions and all of that. And like what Dr. Prem Kumar had emphasized, yes, opioids are definitely not the answer, especially with such a big epidemic going on with the opioid crisis in the US. I don't know how to... Oh, this one up and down? Okay. So just quick thing, and I know, like I mentioned, there's a huge economic burden on chronic postoperative pain management in the US. There's millions and millions of dollars which are spent on patients who still have persistent pain. Why we have it, why patients undergo such stress after the surgery. There's so many theories, so many publications about that. Some classifications here, but I'll just quickly skim through the and come down to this particular model. There's so many risk factors as you look at it. Patients' comorbidities are a very big factor. Patients having multiple comorbidities, including diabetes, hypertension, autoimmune conditions. So any of those pre-existing conditions naturally puts patients at a higher risk of having persistent postoperative pain. One particular problem, which is a huge thing in the US, is opioids. A lot of patients are already on chronic opioid therapy, and therefore eventually end up having opioid hypersensitivity. And certainly those are such a class of patients who continue to have postoperative pain, in fact, more so than the opioid naive patients in the community. So like these are some interesting risk factors there, but I'll just skim through that. So the transition happens pretty slowly, and the trauma, I mean, it could be the post-operative pain has multiple reasons. It could be a nerve injury, persistent soft tissue trauma, bone trauma, or whatever it is. Neuropathic pain seems to be the most common among the post-operative pain patients compared to nociceptive pain patients where you have somatic and visceral pain. The neuropathic pain component seems to be the bigger factor among a lot of research which was done among the transitional pain patients. So what do we do? I just wanted to give some case scenarios. Prevention, like was already been said and discussed, Dr. Prem Kumar mentioned so many medications, non-opioid medications, multimodal analgesia. I wanted to just show you. I don't know where I'm going. I think I missed my slide, but yeah, there's so many non-opioid medications which can be given to the patient and follow up, and then opioids should be reserved to the last minute. However, it's different when with respect to opioid sensitive patients. So they're patients who have been on chronic opioids. I try to reserve those patients to partial agonists such as buprenorphine therapies. So buprenorphine therapy has been a game changer ever since it came out in the market several years ago, because it's the mechanism of action of buprenorphine it's a partial agonist, and so it definitely seems to be taking away or helps with patients with opioid hypersensitivity or opioid-induced hyperalgesia postoperatively. So some of the interventions, I just wanted to through a few case scenarios. These are some of my patients who come to me. So often patients with hip surgeries, persistent hip surgeries, they end up developing persistent bursitis or hip pain. And so these patients, I offer some kind of interventions and they seem to be helping. One particular patients are cluneal nerve treatments. I try to do some fluoroscopic guided cluneal nerve blocks for these patients with the persistent hip pain in either hip surgeries, particularly the posterior, when you're trying to go through the posterior route of trying to do a hip replacements, these patients end up with persistent pain as opposed to the anterior approach where you do the hip replacements. Genicular nerve treatments is a very interesting, very promising treatment which I use for patients with persistent postoperative pain, particularly after knee replacements. Patients have knee replacements. I feel the incidence is really, really high, and a majority of my patients who have total knee replacements, they actually refer to me for either genicular nerve blocks or genicular nerve RFAs in order to tackle the pain, postoperative pain after knee surgeries. That's another one. And then, I just wanted to throw in some pictures there, the approaches and targets where you want to target all three genicular nerves, the superior, the lateral, and geniculars, the inferior and the superior genicular nerves. And so you want to target all three of them. First you want to do a block with some lidocaine or bupivacaine, and then follow up with a radiofrequency ablation. And patients seem to be really benefiting from these kind of treatment options after their knee surgeries. Pudendal nerve blocks, I try to help the gynecologists who send patients with pelvic floor lip repairs or persistent postoperative pain around that area, dyspareunia being a common complaint with women having painful intercourse and all that. And so patients most often in that pudendal nerve area have significant pain postoperatively, and so I try to offer some posterior approach pudendal nerve blocks, where I just approach and the needle target is right near the ischial crest. Go there and then block that with some combination of bupivacaine and steroid. And that seems to be another good promising option for patients who have persistent pain in gynecological surgeries. Back surgery, a lot of spine surgeons, either orthospine or neurospine surgeons, send patients to me for persistent pain post-lumbar laminectomy. And this is a very big chunk of my patient population. At least there's a 30% chance those lumbar laminectomy patients, the surgeries fail. And there's multiple reasons, because it's not as easy as one would think that, yes, okay, you do a discectomy or you do a laminectomy with a fusion, it's all is well. It's really not, because there's so much of innovation there. There's SI joints are involved. So a lot of these patients, I try to do a trial, okay, diagnostic, first do a caudal approach, a caudal epidural, and then and put in some contrast or something like that, and see if that will help. Then if that doesn't help, then there is epidural lysis of adhesions. Adhesions start developing postoperatively at least about 8 weeks after lumbar back surgeries. So patients, and there's so many adhesions there. So if you can, this picture here where you can see the first picture, you can actually see the second picture where there's some filling defects on the left side. And so putting in hypertonic saline and then flushing it through the epidural catheter, you could just see that there's no filling defects post flush. So this is another big chunk. I try to do the epidural lysis of adhesions and try to free up the adhesions, and so that helps the patients. That's one option. Caudal epidural, if it doesn't work, I try to do the this one. If this doesn't work, patients, oh, this is the wrong slide. So try to go in for an SI joint, because remember, SI joint dysfunction is a significant component of post-lumbar laminectomy patients. There's a huge SI joint pain, and so either a diagnostic lumbar or SI joint injections with just simple bupivacaine, following it up with some Kenalog, some steroid with it, seems to alleviate the pain. And sometimes, and these days, you have some newer features, minimally invasive, where you can actually put in some bone graft or bone cement through the SI joint and perform a SI joint fusion. So it's like pretty taut, and like patients seem to benefit from persistent SI joint pain after lumbar laminectomies. So that's another option which they have. SI joint radiofrequency ablation is also another option. So there's so many, patients need to know that there are so many options you can do, like invasive interventional options, without necessarily dependent on opioids as such. So that's where I come in and try to help these patients once they have either a failed back surgery or a failed knee surgeries. And of course, on the other side, you can see a spinal cord stimulator placements. And if everything fails, if the insurance approves, then just put in a spinal cord stimulator and then see if those treatments help the patients or not. So I guess that was it. I just wanted to be very, very brief and say that this is a huge problem, persistent postoperative pain in the community. So most of my referrals which come to me are from orthopedics, knee replacements, knee surgeries, hip surgeries, or shoulder surgeries. They come in for, some interventions or the other, and they, or even the gynecologists, or even, and lately I've been getting some patients from the cardiac surgeons where they do sternotomies, and then I come in and do some intercostal nerve blocks or paravertebral nerve blocks just to give them the option to see if it helps them with their pain. Okay, so yeah, thank you so much, and appreciate your time and effort. Okay, thank you, Dr. Sarina. Thank you. Mm-hmm.
I hope everyone was paying good attention attentively to the talks, and now we will open the floor for Q&A session, about 5 minutes, and we encourage all delegates to interact with our guest faculty, to ask them questions during the day, during lunch, during tea. Please let them have their refreshments, but we encourage everyone to reach out to the faculty and ask them questions, and we will have the floor open for the next 5 minutes for questions. Please ask questions. No question is silly. Please ask questions, and just raise your hand. We'll reach the mic out to you.
Good morning, Dr. Prem. My question is to you. As an acute, pain management people, we are mainly acute pain managing people. How can we identify in that acute period who are the patients who are going to be having chronic pain? And there, I can see even Dr. Elizabeth's lecture, there's a lot there. But how can I apply that to my day-to-day practice? That seems more to me like a researcher's idea, but how does it come to me as a clinician?
So,
Ma'am, generally, what I would like to say is we need to clearly differentiate between acute and chronic. So all patients tend to exhibit nociceptive and neuropathic components. So when we see acute and chronic, what happens is, whenever acute pain is there, it's very site specific, and the pain is severe. It's associated along with a lot of inflammation. But when it comes with neuropathic pain, it doesn't specifically come from a dermatome. And whether there is a trigger factor or not, see, for example, if we have an acute pain, they always have a trigger factor. Whereas some patients with pre-existing pain, that is, some neuropathic component is there, they might always have a neuropathic component. That means there might not be much trigger factors. They might have, say for example, I have a patient already who is having lumbar disc prolapse. This patient comes for, say for example, cesarean. As you know, say for example, let us take an example of pregnancy. You have an exaggerated lumbar lordosis. You give a spinal, and after giving spinal anesthesia, patient starts complaining low back pain, and she goes to her village or whatever, to her relatives, and says, this low back pain has come due to the spinal which the doctor has given. But we never know that she already has a pre-existing low back pain. So what we need to understand is, if they already have I'm just giving one example. If they already have a pre-existing pain of something, we need to identify this in the pre-op assessment clearly, identify that risk factor, make sure that we discuss that properly. If needed, let us have, if in our department, if we have a chronic pain department, let us also have an opinion from them, reassure the patients that this is not the one which has caused them. And if they give a consent, let us go with the anesthesia of choice, whatever we have, and tell them that this factor is not attributed to that. I'm just giving one example. So to prevent this patient going into, and there is a lot of evidence if a patient already has, say for example, a L4, L5 disc prolapse, you go in the same space and you give spinal, there might be a little bit of epidural hematoma developing, and this might exaggerate the pain which he already has. So we have to review the imaging, get a proper history, do a neurological examination, see where she has that pain, and avoid, say probably we can avoid that space and go to a space which is lower than that. So we have to take some certain decisions of avoiding or exaggerating a pre-existing pain. I'm just giving one example. Yes, ma'am. Ibuprofen.
Third option only diclofenac, no?
Yes, ma'am.
Is that mechanism of action is almost similar? Is it based on the people use it, or is it any problem with the thing? Have you come across
Madam, it's just only about the adverse effects caused by that. Okay. So when we see diclofenac, as you know, one major contraindication is patients with heart failure or patients having CAD which compromise LV function. These become a absolute contraindication for diclofenac, where in the same patient ibuprofen has been proven to be a little bit safer.
So depending upon the the literature is based upon the
comorbidities, yes, and complications.
Yeah,
the incidence of complication which has come to the drug itself.
Sure, thanks.
Patients who come with burns, extensive burns, and they are the ones in severe pain, and those are the ones that we finally revert to narcotics and opioids. So is there some alternative for them? And because it's in different parts, regional blocks are not an option. So what are the options for patients like that?
Say for example, in our country it is very difficult to get oral ketamine. Oral ketamine is there. It is available in market. So if there is an option of getting oral ketamine, we can give them. Otherwise, we have to, along with, apart from morphine, obviously from opioids, we have to use opioids. Ketamine is definitely a good option. And if you have a pain clinic, there is a protocol for using IV ketamine infusion. We have to give 0.5 to 1 milligram per kilogram weekly thrice for 8 weeks. So if we give this, follow this regimen, we used to give this for burns patient in a pain clinic. We used to give this for psychiatric patients who are who have resistant depression and they have suicidal tendencies. So these are the two current indications, and patients who are on very high dose of analgesics. So probably these are the three indications where we give IV ketamine infusion, but with a setup where will be able to monitor. So we usually give this for 30 to 40 minutes, IV ketamine infusion.
To all the experts, I just wanted to ask, in your experience, do you see neuropathic pains are going up? Because now we are going a lot to peripheral nerve blocks, and different places, there are learners, a lot of people doing. Accuracy is different in eyes of different people. A few people are very particular, few people just go, come out, needle in, out, in, out. Do you see the neuropathic pain going up?
Actually, one thing is there, of course, now we are able to identify them much better, because I still remember, you know, my mother had herpetic neuralgia. That was, I think, 93 or 94. She was given first choice at diclofenac, which is not a good drug for her herpetic neuralgia. So awareness is more, and second thing is we are probably many people are being trained to handle the neuropathic pain. A lot of guidelines are there. More than anything, don't forget, our lifespan when we got independence was around 32 years. It became 47 years by, I should say, by the time we reached the 1980s. It became 54 years in 2000. Now the lifespan is 70 for women, 67 for men. You don't ask why 3 years less for men. No, so I'm not talking gender equality here. But once you live for longer time, when you had independence 32 years, now it's 70 years. You live for longer time, you have to pay that almighty some tax. You collect in the form of pain. Your degenerative spine, neuropathic pain, diabetes. They are more age-related only, predominantly, unless you got juvenile diabetes. It's more like lifespan, and detection is much better.
My question to, sorry.
Madam, I just wanted to answer that specifically what Dr. Ekta said. Today is like most of the, because we have a fellowship program, we have specifically trained a lot of people. Whenever you do a peripheral nerve block with ultrasound guidance, it is a big tendency where youngsters take the needles, especially when they are doing it, when a supraclavicular is done, they just go deep enough, try to deposit. They just see the injection pressure and deposit. See, as of now, the best evidence internationally is no needle, no contact technique. This is the best evidence available. That means you can puncture sub-epineurally, but you cannot do a puncture perineurally. And that is not, you have to understand that sub-epineurial extravascular is the only safe thing. And even with the best ultrasound machine with the best resolution, you cannot differentiate epineurium from perineurium. So in that case, what you need to do is take a very blunt needle, that is, you have an ultra needle, either Pajang or Braun, whatever it is. Don't do with spinal needles. Don't do with all these cannulas, IV cannulas, which is sharp ends. Always do with a blunt needle. If you are not sure enough, just deposit the local anesthetic around the plexus. Never penetrate it. If you are going to penetrate it, see, I have lot of differences of opinion with even Dr. Sivashanmugam related to that. We have argued a lot, but he might be a person with different expertise. But as of now, with related to safety, subepineurial, extravascular is safe. But I don't think a person who is just started his regional anesthesia career can differentiate this. Just deposit above the epineurium. Even if the block doesn't take up, not a problem. We can always go ahead safely with general anesthesia. But don't cause neurological deficit.
My question to Dr. Elizabeth, what is the evidence for neuroplasticity? Because most of our patients are awake while we are performing the procedure. So the way we speak, the way we perform, the negativity or the casualness, and especially the chronic, both acute and chronic. So it's important how we do the procedure, so that enters the patient's biology, neurobiology. So so how we can improve that, and there is evidence to show that there is neuroplasticity and there is neuro destruction as well. So your comments on those?
This I think comes more towards behavioral pain modulation, And so that's what actually they say is a very important component when you're looking at multimodal strategy, where actually the focus on that is very minimal. So when you're talking about plasticity, which is why pre-counseling in fact plays a huge role, explaining to them the procedure. In fact, they see the pain scores come comparatively lesser as compared to the others. But again, that has to be done in combination with improving your techniques too. And regarding that with potentiation of plastination, what they see is if you reinforce even the same information again and again, it causes enhancement of your glutamate receptors, which actually causes pain modulation. So that has also been known and reported. So I think it is an important component not being explored as much in combination with the current models of treatment.
I'd like to ask one last question, and then with that we'll wrap up. Is there anybody else with any burning question to be asked? Otherwise, we would encourage to approach the faculty during the tea time and to interact with them. I have a question especially directed to Murli sir and Prem sir. Majority of us over here are anesthetists. I'm also an anesthetist with an interest in pain medicine. How would you balance anesthesia and pain medicine, or make the leap from an anesthetist to a pain physician? If you could inspire the anesthetists over here, a lot of them are PGs, it would be really nice, sir.
Actually, it's not that easy. Not that, but it's not impossible, because if you work in a department like institution, like something like this kind of institution, then probably like what happens, like somebody who is interested in that one, they can go for that particular pain, whatever. But most of what used to happen earlier was many departments had shortage of anesthesia people, so they were not willing to relieve them for the pain clinic work. Now with so many seats being there in post-graduation anesthesia and so many fellowships and all those, so many hands are coming out, that should not be a problem. And of course, it's lifespan is going up, need of the hour. You have to have it, you can't help it. So sometime, or in fact, NMC also mandatory that every medical college should have a pain clinic. That is if you're an institution. If you're in a corporate hospital, of course, you'll be a basic pain consultant, you have to do some fellowship or something, at least 1 year additional training, because most of the medical colleges still do not have sufficient faculty, sufficient load. If you want to go for freelancing also, you need a fellowship and all. Of course, whatever MD anesthesia qualification you have, that's good enough for you to practice your pain medicine. Fellowship is only for you to get an additional focus. It's better not to do a mistake and try to learn, rather than learn under somebody.
Okay. Yes, ma'am. So what I would like to advise is, we need much of the pain clinic departments doesn't have the support of department. This is the biggest problem with most of the pain clinic, and most of the pain physicians are always isolated. So bigger problem is, this is not only with any institution. This is this is generalized to all the institutions, and I think it is even generalized to all over the world. They are always isolated. So what we actually need is the support from the core department. So if something is very integrated and you start to show quality work, just one example is initial days when we were started to use fluoroscopy for TFSIs. Orthopedic surgeons and neurosurgeons were very resistant to us. Even our own HOD was very resistant, and he said, how can anesthetists start using fluoro and all this stuff? So we had a lot of resistance. But once we started selecting the right patient and putting the right evidence, the incidence of unindicated lumbar disc surgeries, especially like lumbar surgeries, has gone down by almost 50% in our institution. So that is a big success to any anesthesia department as a core. So we can contribute a lot when it comes to multidisciplinary management. So we need to have a good care pathway, just like how UK has. And if it is very much good integrated, we can make a lot of difference in any institution.
Just to add on to this, water training, especially for postgraduates who are doing anesthesia, there is a fellowship from the national board. You can appear for those exams. I think the centers are in One is in Chennai, one is in Calcutta, and one is in, I think, Gangaram Hospital, Delhi. Or else you want to go for the fellow, you can do it in RN Institute, Delhi also, fellowship. Otherwise also you have DM courses which have started in Hrishikesh, AIMS Hrishikesh. And many other institutions it's coming up. So you have a wide opportunity, wide scope, and subsequently you will be starting your own pain medicine department, wherever you will be going, or you might be working within the department. Options are that. Most important is what I would like to say is that exposure for 1 year is always important, because then you become okay, you'll come out like a complete physician, rather than going for a short course. Short course for updation or for seniors who cannot go for 1 year. Okay, but for postgraduates, I still suggest you go for the regular program. It will help you a lot.
My question is to Dr. Tuin. Dr. Tuin is also very experienced and a regional anesthetist. How do you choose your local anesthetic for best and optimal effect? Like, do you mix it? Do you give single drug, or do you give one after the other? What is your practice? I know Dr. Arish has nicely spoken about the concentration and volume. Could you just give your thoughts on this?
Yeah, thank you, madam, for having me here. Local anesthetic choice actually based on the indications, and patient profile, lot of factors comes into it. But on a gross note, I can say that if you are using it for the anesthetic, we usually use the higher volume, as he has mentioned already, more than 0.375%. And the lower volume like 0.2%, 0.1% of ropivacaine, or motor sparing if you want, so go for ropivacaine, and if you don't have the ropivacaine, then we can go for the bupivacaine. But keep the concentration very low if you are using for the only for the post-op analgesia. But again, intra-op also, if you are using general anesthesia along with the local anesthetic, then also you can cut down the concentrations. So it depends on many factors for what you are using it. Anything else? Yes. Thank you.
Question. How do you calculate toxicity when you are mixing two drugs? I think this question has been there for 100 years, still not answered.
Madam, again, toxicity depends on many factors. Local anesthetic toxicity itself is a misnomer term, because that toxic dose, what was calculated, is based on the epidural dose. So peripheral nerve block, when we are doing, actual dose is 10 times higher than the epidural dose. That is the actual toxic dose. But what we read in the books and the papers, that is according to the per kg body weight, that is misleading. So depending on the place where you are depositing the local anesthetic, suppose for example you are depositing in the caudal, or you are depositing in the supraclavicular brachial plexus, that will have much lower dose for toxicity compared to a median nerve you are doing in the forearm. Okay. So depends on many factors, patient profile, the vascularity of that area. And regarding your mixing, you are telling, mixing always decrease the threshold. So it decreases the duration, as well as there is a adding factor of the toxic profile. So it will be much more toxic than the individual element itself. But again, that toxicity also depends on those factors.
I just wanted to one more add to Serena ma'am's. The question was whether to mix or not to mix. What will happen to the physicochemical properties of individual local anesthetic? I think that's what is being done with Shiv Shankar sir, a recently published RA-CME journal, where they try to mix lignocaine and bupivacaine, where most of us think it will be 1% lignocaine after mixing and 0.25, and whatever I said, it's going to contradict to it. So, but what the complete conduction block compared in a plain lignocaine group is achieved almost 14 minutes. And with the mixture, it is almost 16 minutes. There is no much, it is almost comparable. But when you really don't want to mix and you're going to give a bupivacaine alone, you just imagine it almost took 40 minutes for the complete conduction block. Do you think our surgeons will really wait there? It's a quiet thing. But we have to see in a holistic way. What really happens to the patients who receive lignocaine alone? It will act only for 1 hour at the max, or 1.5 hours. And what will take care of the post-operative analgesia? So when we combine, it gives another post-operative pain analgesia which the bupivacaine takes care. And really the onset is more pronounced because of adding lignocaine to that. And if you mix ligno with adrenaline, the adrenaline plays an important role as a vascular marker too. So we have not established bigger liquid chromatography methods of seeing all those mixing natures, but yet we need to find it out a way to answer all those questions.
I'd like to thank everyone who's asked a question, and we would like to honor our guest faculty, and I would request our head of department, Ekta ma'am, to honor Muralidhar sir with a small token of appreciation from our side. So on the stage. So, Dr. Muralidhar Joshi sir, thank you so much. Next, I would request our Serena ma'am, ma'am, to honor Dr. Arish. Thank you, sir, for the wonderful talk. Our head of neuroanesthesia, Dr. Ramamani ma'am, to honor Dr. Elizabeth Vinod. Thank you, ma'am, for that wonderful presentation. I would request our professor, Dr. Smita Elizabeth, ma'am, to honor Dr. Prem. Thank you, sir. I request Dr. Karen ma'am to honor Dr. Sanjay Murala, who has come from the US. He's an alumnus. Thank you for coming, sir. And Dr. Aparna ma'am to honor Dr. Tuhin. Thank you for coming. Thank you so much. Just a few important announcements and reminders. But before that, we'll have. I'd like to acknowledge our internal faculty, and I'd request them all just stand up in your places so that all our delegates know who you are. All our internal faculty, please stand up wherever you are. Please stand up so that our internal faculty. Thank you so much, ma'am, Serena ma'am. Yeah, thank you so much. And we have a lot of delegates. A lot of them are our internal delegates. I'd request our PGs to just stand up in your places. Yeah. Please come on, Abella, Abhishma. Yeah, these are our PGs. A lot of them are here. Then our external guest PGs, please stand up wherever you are. Just help us identify who you are. The PGs who have come from outside, please stand. Yes. And our consultant delegates, we have a lot of consultant delegates as well, both internal and external. I request you to just stand up and identify yourself. Consultant delegates, yes. And we have a lot of doctors who are with our network hospitals, our mission hospitals. They have also come from far, and we would like to welcome them. Dr. Amy, Dr. Dakar, and even we have faculty from our Chittoor hospital also are here. So I'd like to thank all of you for being here today. Before we proceed, just a few important reminders. So the next session, the quiz will be in this hall itself. I request all the PG delegates to have your tea quickly and please come to this hall within 10-15 minutes. Please do not use the entire duration of tea. You have to come here, you have to find your group members. You are divided into 8 groups. I hope you have all received the invitation email. If you have not received the invitation email, please approach our reception, which will be downstairs on the ground floor. The tea will be ahead of that. You can find your groups and please sit in your groups and then we can have the quiz. The quiz will be on an online platform called Kahoot. You will have to download the app. If you are not happy about downloading the app, you can use it online itself. You just have to type kahoot.it, Kahoot it, and the QR code will come, the number code will come. You just have to enter that code and the quiz will start. I request the consultant delegates after tea to immediately proceed to the ground floor anatomy dissection hall. The ground floor anatomy dissection hall, we are very tight, we are going on time, so please do not be late. The session will start and we would not like anyone to miss the session. So to get the maximum out of today, I would request all the delegates to be very conscious of the time that we have been given. Some other things that I have been requested to point out is we would say that photography is strictly prohibited, especially of the people who have been kind enough to donate their bodies to science. Please do not take photography in the anatomy dissection hall. It is strictly prohibited, and do not take photography of our live volunteers. We would like to respect their privacy. So please, photography is strictly prohibited. Do not take photography without consent, and we are not they have not consented for their photographs, and neither have the donated people who have donated their body to science consented for external photography. So please do not take photographs. Every delegate has been assigned stations A1 to A4 and B1 to B4. I hope you know your station details. In addition, PGs have been given group 1 to group 8. Details are with the reception. Please do not carry any bags or luggage into the anatomy dissection hall. There are cloakrooms available for that, and please put all the disposable items in their designated biomedical waste management system. Bins are there. Please put them all over there. And restrooms are available on each floor. Any issues you have, we have volunteers with red bags, and we have multiple people available to guide you through this day so that you can get the maximum out of it. I would now request everyone to just come forward while we for a photograph. So we'll huddle around together in the first 3-4 row. All the PGs just come ahead from the back so that we can huddle and we will take a photograph with. So everyone can sit over here in the first few rows and we will take a photograph from this. Please come forward. We will not be seen in the photographs if you sit in the back. So please, we would like to stay on time. So please move ahead. Thank you so much. Please come ahead. I request all our faculty to please come ahead. All our faculty to please come ahead and occupy the seats in the front. Please come forward. The first 4 or 5 rows will only be visible.